just ask everyone who's not speaking to just mute, because there's quite a bit of background from a couple of people. I have requested some help to deliver this seminar today. So in addition to the team from the Netherlands who are going to be organising and curating all of this, I have asked for an additional speaker. So everybody meet Alejandro, whose voice or his dulcet tones you will recognise from the Realist Lens podcast series. So Alejandro, if you want to put a link in for anything for anyone to sign up to that, that's great. I have got to dash off. So those of you who don't know, my academic contract has ended and I now run the Realist Hub as a business, which is exciting, and I've got some new news to tell you. I've applied for funding and I've been asked today to go to to give a pitch. It's like being a salesperson, which is not really my comfort zone. So I have to leave around 2:15 to go and do a pitch, and I did ask if they would give me another time zone and they said no. So Alejandro is going to swap his Realist Lens hat and take over the hat of the Realist Hub on the day that we have got the most ambitious seminar that we have ever tried to do. I'm really excited and also scared stiff at the same time. So Alejandro, do you want to just introduce yourself? Tell people who you are, what you're doing, where you're based, because you're based in two places really, because you've got your PhD and you've got the job. So do you want to just fill the gap and introduce yourself to people? I don't know if you've got a slide or anything like that. If you want to put a slide up, it's up to you.
No, real quick, I think I echo everyone's comments in the chat that best of luck today. I know it's a very exciting opportunity. You know?
I'm so scared.
But I'm sure you'll be absolutely fine. Hi, everyone. As I usually start my podcast, good morning, good afternoon, good evening from wherever you are joining us from the world today. So my name's Alejandro. I am based in London, although I do my PhD part-time at Lancaster University, and I also work as a mental health researcher at the University of Victoria in Canada in realist projects. I love realist things. I love realist stuff. And I find it really fascinating to see how we can also engage more audiences in accessible ways to understand the realist world. My field is in mental health, although I'm very interested also in the methodology of realists and the approach of realist. So that's enough about me, because the most important thing is that we get straight into the session. And I'm just happy to be able to help with the questions today in the 30 minutes at the end. And I'll just try to be a glue between the questions that you want to ask the lovely guests that we have today and also some of the answers, and move that forward. But that's enough, and really nice to be here today. Thank you so much.
So thanks, Alejandro. I am so grateful for your assistance today. So as I mentioned earlier, the Realist Hub has now operated as a business, and as a business, I have now diversified slightly. And Lauren, have we got a slide? Have we got something to mention just very briefly about training? So I very quietly launched a training program very recently on the PhD network that Alejandro runs, and I have one space left. That's it. So I'm really surprised because I've hardly had to do any advertising. So if anybody wants to join this training, it's around program theory. So it's a massive deep dive over 4 sessions into program theory. There's more information on it which I can get to you, but these are the dates and times. So if they correspond with you, then Lauren, can you put the link into the job form to sign up for the one person who might be lucky enough to get the last space? But if you are not able to attend the session, or you don't manage to bag the last slot and you want to do training, can you fill in the waiting list form? Can you just let me know? There's a little bit in the paragraph there. Let me know what you would like training on. Now, generally, the work that I do, realist work, is one-to-one. So the training I've organized is really small, no more than 10 people. So I give an element of one-to-one. You will get a 30-minute one-to-one session with me during the training, and a 45-minute one-to-one with me after the training has finished. And that is worth over £200 alone. And the training at the moment for this cohort is £375. There will be a small increase in January for future training, but we can look at anything. We can look at reviews, we can look at evaluations, we can look at interviewing, we can look at lots of different things. The idea is, from all the training that I offer, be very practical, and you will be able to come away with tangible learning that you can implement in your own projects. So if you know you have a burning desire to learn something and you're quite keen to come to one of the trainings that I offer, let me know and I will organize training for that. So now that I've mentioned that, because I won't be around at the end, I don't think. If I can, I'll come back and I'll let you know how it was. I'm going to, Lauren, can you also just give us the details of the next talk? So coincidentally, the next talk is also Alejandro's. So Alejandro is presenting next month with his colleague Mita. So we will be posting this properly on the Ramses Just Mill later this week, but the talk is now live. Lauren, if you could put the link in for the Humanitics into the chat, that would be great. For anyone who's got a smartphone, you can sign up via the QR code there. But we will post that separately as well, and it'll also be on LinkedIn. In fact, it'll probably go out on LinkedIn first because Lauren does that and I have to do the Ramses, and she's usually more on the ball than I am. So that's everything. I think that's all our announcements, I think, isn't it, Lauren? Shake or nod? Yeah, perfect. Right, so today we are embarking on the most ambitious thing that we've ever tried in the Realist Hub. I have been doing these seminars now since COVID. So I started in 2020 with a session from Andrew Booth when we were operating as Not Realism. And this workshop is hosted by a wonderful trio, the Dutch speakers, Dr. Rowan Smeets. Do you want to give us a wave, Rowan? Right, now I've just Nienke de Graef, whose name I think I've pronounced correctly, but she'll shake or nod or educate me later. And this is the one that I'm still learning. So do you know what? I'm going to get it wrong on a Dorijn?
Hello,
Dorijn. Yes, okay, Dorijn. Okay, Dorijn. I need education on the surname there. Right, and you are all from the Department of Health Services Research at Maastricht University. And I did meet all of you in summer when I came over. I know I met Nienke because we had a good chat, but I don't know if you were all there. But I had a lovely time in Nijmegen, and I'm getting better at pronouncing that as well as spelling it, because that improved over the course of the thing. Anyway, that's a separate story for another day, and the people who were there understand. But over the past few years, they have developed expertise in realist research, and they've conducted a realist evaluation of a complicated integrated care program and a realist review on shared decision making for patients with limited health literacy. That's quite interesting for me as well. You've shared your insights at national and international conferences and integrated them into teaching at Maastricht University. That's quite impactful. Perhaps we should do a session on impact. So this talk, Uncovering the Black Box, the potential of stakeholder engagement and realist evaluation, has two aims. One, to help raise awareness and understanding of realist evaluation. And so those people who are new to realist evaluation will get a lot from that aspect, and its application in integrated care, and to inspire and equip participants with practical tools for conducting realist evaluation in co-creation with stakeholders. So those of you who are out there who are trying to develop your own realist evaluations and your own co-creation, and I do a lot of co-production in our research, you're always looking for new and innovative ways to do co-production. Yes, we're using the integrated critical care as a tool, if you like, but what you will be able to take away is an understanding of how you can then apply that into your own research. That's my understanding of that pitch. Is that correct? You three nod? Yeah, or shake and say, no, Joe, you've got completely wrong idea. All right. So using the Hats of Bono, I just don't think is part of you two. And for those of you who are young, you won't get that, but okay. Participants will practice realist thinking and explore ways to collaborate with stakeholders. The workshop will apply 4 hats, we've got them coloured as well, to elicit feelings, ideas, benefits and critiques around realist statements from a real life case. Now, I don't have individual bios, and I think if we did individual bios, we'd still be here at 2 o'clock talking about you. So I'm very sorry to apologise that, but if you want to add anything on, you're welcome to, especially when we get to talk to you later. Does that sound all right?
Yes, thank you, Joe, and good luck in a bit with your pitch. You'll do great.
Well, we'll see about that. We'll see about that.
Fingers
Could be
crossed.
interesting. Right.
Yes.
So, do you want to start and then we can break? Do you want to just give start with a brief intro about what we're expecting people to do, and then we can work down? We've got 37, so I think we were about on the nail for what we said. So we're probably looking at about 8 to 9 in each group.
Yeah, that's okay.
Yeah. Shall I share?
Yeah, we have a presentation as well.
Yeah.
Then we can.
Perfect.
Thank you very much, Joe, for this invitation.
Yes.
Yeah, and for this opportunity to share our ideas and insights and knowledge. And it's also, I think, a great opportunity to network and to hear something back from other people in realist evaluation. Yeah, then we can start with I think a small presentation that we have prepared for you. And then after that, like Joe said, I think a large part of the workshop will obviously be interactive, and we'll be applying some of the insights that we got from engaging stakeholders in realist evaluation. Yeah.
Maybe we can start with introduction.
Yeah. So maybe a quick introduction round into us. I think Joe already introduced us a bit. So we all work indeed at the Department of Health Services Research at University of Maastricht. That is a university in the south of the Netherlands. We all our research is part of a living lab and sustainable care, which means that we are very much focused not only on research, but doing that in close relationship with practice, with policy, with education. I was very much, in terms of realist evaluation, very much focused on an integrated care program, the Target program. That's a Dutch innovation for primary care. And we felt when we thought about how to study this and how to evaluate the effects, we very much believed that we needed something else than something different than an experimental design. So we found realist evaluation, and it was quite it was quite an opening to for us to a new world of making sense of these complex innovations. So we are still, I think, in the middle of doing this realist evaluation and deriving lessons from that. Maybe Nienke and Dorijn can also talk a bit more about their work, their experience in realist evaluation, or
yeah. So we're also in the same room, by the way. So if you see us looking at each other, so we're also doing a realist review, like Joe mentioned, on looking into shared decision making as an intervention for people with limited health literacy. And it's been really interesting. It's been ongoing for more than 2 years, and it's really nice to have learned more about realism, but also realist evaluation as well. And besides that, we also have a patient group that we formed with people with type 2 diabetes and also various health literacy levels for patient involvement, which is also like rising in interest, of course. And I think
they are our expert by experience.
Yeah, our expert by
co-create research with them.
Yeah, exactly. They're a citizen scientist, and one of the ways you can co-create with stakeholders is Hats of Bono. So we'll be learning that today as well. So I think that's very interesting, not only for within realist evaluation, but also for other research areas outside of realism. Yeah.
I think I have anything to add.
great.
Okay.
Okay. Yeah, so I think Joe already touched upon this. So goals of today are that we will start in a bit with giving you some insights into how we see realist evaluation, how we see potential for stakeholder engagement, and tools that are developed for stakeholder engagement to use that in realist evaluation. And then the largest part of this workshop will be obviously devoted to practical application, which we will do in subgroups, but also we'll have a plenary discussion at the end. Yeah. So we were wondering what the experience is with realist evaluation in this group. So we can also maybe tailor it a bit and know what to expect based on your experience. So could you please maybe raise your digital hand if you have no experience with realist evaluation at all?
Quite some hints.
Yeah. I think around 9 people. And then please lower your hands. Yeah, you're already doing that. Because who has limited exposure but not really applied it maybe in a project? So you have a basic understanding of what it is, but not yet used it.
So 9.
Also 9
Yeah.
people. And please then lower your hand again so we can see who has like moderate experience, so applied in some projects.
16, I think.
17, yeah.
I think that would be the largest group. And then people who say, well, I have extensive experience, I've consistently applied it in various projects over the years. It's obviously Joe, and it's obviously Alejandro. Yeah. Okay, that will open up.
I think.
Yeah.
Oh.
No. Good luck, Joe.
Good luck.
Thank you.
I'm
Oh,
not doing it. I'm just saying yes. It's me. I'm still here.
Yeah.
Next one.
Yeah. So yeah, that's good for us to know. So I guess that many people at least have a basic understanding of realist evaluation, but there is still a group of, I think it was about 8 or 9 people who are quite unexperienced with this approach. So it would be good to tell you a bit about how we see realist evaluation. Yeah, so realist evaluation is a type of theory-driven evaluation. So I think also Paulson and Tilly, who are the founding fathers, you could say, of scientific realism, they say, well, realist evaluation starts and ends with theory. And with theory, we mean not just something very abstract and based on all kind of literature that is out there and assumptions. It could also be knowledge. It's actually just a current state of knowledge, insights. But if you're not yet there, then it's more like the assumptions or the ideas, the expectations that you have about how a program functions. And I think that is a core that you also plan your research on. And so when one evaluates realistically, you always return to that core theory about how a program is supposed to work, and you start to sort that out. You start to test it. You try to find evidence for it by conducting interviews, by doing some literature review. And it's constantly changing and dynamic. You can constantly fill it with new insights and adapt and improve it. So obviously, the main question that you ask yourself is not only what works or does this work or if it works, but rather what works for whom, in what circumstances, and how. And that is also, I think, really these new ideas of the deeper level of understanding of how a program works that is also advocated by Paulson and Tilly. Yeah, next slide, please. Yeah, so this might also be familiar to most people, the CMO configuration. So it's a configuration of context plus mechanism is an outcome. And I think this also really aligns with the idea that outcomes, they don't, from a realist evaluation perspective, they don't come about just by turning on off an intervention or by implementing an intervention. It's always a dynamic interplay between the intervention that has some resources that you implement within a certain context. And if you have that right supporting context, then also mechanisms, which are actually at the heart of change, can be activated, can be triggered, and that can lead to all kinds of outcomes. I think the next slide will give also a bit better idea of what we mean with context, mechanism, and outcome. So with context, we mean anything in a physical and social environment that is relevant to explain, to help you understand why programs work, for whom and in what circumstances. And a context can stimulate, can be positive, can have a positive influence, but could also obviously obstruct, have a negative influence on the activation of mechanisms. Then mechanisms are I think it's often framed as the core of change in people. It's about what it is about a program that actually makes it work or not, and how actors respond to this. So I think mechanisms are often described as these latent hidden forces like trust or confidence, could also be pleasure or fear, that under the right circumstances can be activated. And based on that, people can actually change their behavior. They can do something differently. They can realize something. It can lead to all kinds of outcomes for different stakeholders. And when it comes to outcomes, I think realist evaluation also has kind of a broad idea of what an outcome could be. So it can be what you intended with a program or an innovation, but it could also be unintended consequences, unexpected things you didn't anticipate on. And it always results from the activation of different mechanisms in different contexts. So we try to give you an example of one of the innovations that we worked on, which is I was just referring to that at the beginning. So we worked on an integrated care program called primary care, which is kind of a complex social program, you could say, where we, for instance, designed a person-centered consultation. That is a consultation between a GP and a patient, which is broadly about what is going on for a patient, what is the root cause of this of health problems that this patient has to deal with. And we found out that if you have a context where the patient and care professional really trust each other, then a person-centered consultation can also give that confidence, has the right circumstances to actually confidently discuss health in a very comprehensive and personal way. And that can lead to patients who feel heard. So here, I think you also see that while trust can be seen as a very typical mechanism, it can also be an important contextual factor that actually is important for new mechanisms to be triggered. Next slide, please. So why realist evaluation? I think there are various situations in which you can use realist evaluation and where it can be helpful. I think a couple of situations are in particular helpful for realist evaluation. So if you have a new program, I think it can help you to think about what to expect from my program. What kind of methods do I need? What kind of outcomes would I need? What kind of stakeholders do I need to involve? Or do I have to interview or need to be able to send a survey to? Or so it can help you to plan and design, I think, make decisions about methods, about planning in your research. And then it is also, I think, in particular helpful if you want to evaluate programs that will be scaled out or that will be implemented in a different setting, because realist evaluation has so much attention for what setting do you need, what contextual circumstances do you need for a program to be successful. So if you want to scale out and implement in a different setting, you can also make up your mind about what to expect if I have a certain context, or what preconditions do I need to first work on before I can be sure or relatively sure that this program will have the same effects as I got before. Then I think it's also in particular helpful for programs which have mixed effects, because you can understand, I think, better not only the reasons for success, but also the reasons for failure. So maybe it's the case that for some actors it did work, but for others it didn't. So I think with realist evaluation, you can pinpoint what type of actors will actually be helped and be supported by this program, and what actors will not, and what contexts are related to that, or what mechanisms do come about for different stakeholders. And I think that's also a way to learn from failure, is also obviously a way to improve and adapt programs and your efforts. Yeah, I think that was kind of an introduction that we wanted to give on Realist Evaluation. And now Nienke will take over for a bit of insights into how to use that for co-creation and stakeholder engagement.
Yeah, thank you, Rowan. So we'll start with an opening question. Why do you think stakeholder engagement is important or can be important in Realist research? Maybe some people who want to speak up can raise their hand, their digital hand. And otherwise, you can also use the chat, of course. Genevieve?
Hi. I think it's really important to involve stakeholders because that gives you the essence of what is actually important in an evaluation or in a review itself. So that's why is that they're the people on the ground that actually know what's important to start off with.
Definitely. Thank you so much. I also saw Faye raising her hand.
Hi, I totally agree with that previous point. I think it's important in all research, first of all, to it's that nothing about us without
Definitely.
us, that there needs to be some, but particularly in realist research, I think it's very easy for researchers and even practitioners to think that they understand how and why something works. And the challenge that comes back from actually people who are in receipt of services can be really, really important and uncover new information and new theories about why something works as it does or doesn't.
Definitely.
Yeah.
Thank you. And I also see some people putting something down in the chat. So Natalie says understanding context. Michelle says not all theories are in the literature via other sources. Yes, definitely. Megan said no research without stakeholder engagement to decide the question and later particularly for understanding the mechanisms. Yeah, definitely. And they are the experts by experience. Yes. Oh, and I see Caroline also raising her hand.
Yeah, hi. I agree with all those points. Something I'm curious about with realist evaluation is where the line is between a participant and a stakeholder, because to me it's quite an involved process of co-creation with participants. So I'm kind of curious sometimes, like, where's that? When is someone a stakeholder and not a participant, or a participant but not a stakeholder? So yeah.
I don't know whether you want to cover that now. That's quite a heavy methodological question. I would normally say stay on at the end and I will go into that in depth with you, but I may or may not be back. So can I say let's try and coordinate around that at a future point, because unless you want to go into it, but it is quite meaty and it can take quite a lot of involvement to unpick. It involves all sorts of different things that you need to look at, if that makes sense. But it's up to you whether you want to go into it now, Nienke.
Yeah, maybe we can get back to it later in the end. And if Joe's not there, we can also discuss it further then when we have a bit more time, if that's okay with you. But a very good question, I think, indeed. Okay, thank you. So, like everyone said, to sum it up, yeah, co-creation is essential, like you all said. The emphasis is understanding the relevance and the context aspects that those stakeholders in practice likely comprehend better than most researchers. And realist evaluation, like Rowan just mentioned, operates on the premise that an innovation can have varied effects on different individuals. So consequently, it's essential to include these stakeholders in your theoretical framework, seek their perspectives out, and also customize the theory for each actor. And this approach is, a vital aspect of realist evaluation, but not only realist evaluation, but really every type of research. At least I think we should include stakeholders and especially the patient to ensure a more comprehensive and also more nuanced understanding of how those innovations can impact diverse stakeholders. And this can be done in various different ways. We really prefer the creative ways, and one of those creative ways is the Hats of Bono. Yes, next slide. Okay, so first off, if we approach a problem from one direction, then the answer we might get might not be a good one. And if you look at a decision from just one perspective, then the decision we make might be a weak one. That's fine. But if we can approach a problem or look at a decision from multiple angles, we get more ideas, better ideas, and more robust decisions. So with this, what I'm trying to say is, if you approach a problem from one direction, so if you have on one type of head, which I will explain in a bit, then we're not looking at it in a good way. And if we look at the decision from this one perspective, then we also might make a weak decision. So look from multiple angles and multiple perspectives to really get a whole overview and a better overview. And how we do that is with the Hats of the Bono. And we have 6 different colored thinking hats. And what is the Hats of the Bono? So it's a method that promotes creativity and decision making. And like I said, there are 6 different colored hats, and each color symbolizes a different way of thinking. So this continuously provides different directions on the topic at hand. And those 6 thinking hats enable a group of people or stakeholders to think constructively together in exploring and implementing change, rather than using arguments to fight over who is right and who is wrong. So maybe you have experienced that you're together in a focus group or stakeholders, and people come in and they have the black hat on, for example. So the black hat is kind of devil's advocate. So when you put that hat on, you look at the problem with caution and with criticalness. But sometimes it's good to take off that hat and put on another hat, for example, the yellow one. If you put on the yellow hat, you look at the problem with brightness and optimism. And maybe then you also want to put on the green hat to look at the possibilities and creativities when you think about the problem or trying to make a decision, kind of trying to think outside of the box. The red hat is also really important because that's a hat you put on and think with your feelings, hunches, and intuitions. So maybe you feel a certain way about this problem or the decision that is made. And then we also have 2 other important ones that we'll be wearing today, and those are the blue and white hat. So the blue hat is the reviewing your thinking process. So it's kind of the manager of the group, making sure the process runs smoothly and all the hats have their say. And then you have the white hat, and that is collecting the facts. So the background facts that you need to know to make a decision or to even discuss the topic. Yes, so this is a slideshow that I will also share with you in a bit before we leave for the breakout room. So you can check this explanation again, because this stick figure also explains what all the hats are and what questions you can ask yourself when you have that hat on. Yep.
Okay, so for the workshop part, you are going to work with a case, and it's a fictional case. But I'll explain a little bit of the background, which is unfortunately very true, the background. In the Netherlands, but also in many other countries, we are dealing with an aging population. And that means that we have more and more people with chronic disease, and oftentimes these people have not just one chronic disease, but multiple, which leads to an increased workload among healthcare professionals. And they suffer from burnout, which can then lead to staff shortages, which again can lead to more increased workload. And what we've been experiencing in the Netherlands more recently is we have a very strong general practitioner system in the Netherlands. The general practitioner is the gatekeeper here. That means that if you suffer from any physical or mental problem, then you visit the GP first before he refers you to anywhere else in the healthcare system. We are used to having a 1 or 2 day waiting time to visit a general practitioner, but waiting times for non-urgent complaints may now be as long as 2 to 3 weeks. So that's quite a big problem, and GPs warn that patients are no longer receiving the care that they are accustomed to. What we see is that complaints from patients are rising, especially among young families who struggle to get same-day appointments for their sick children, or also among older adults with chronic illnesses who require regular checkups, but those checkups cannot be regularly provided to them. So we have come up with a new idea. It's fictional. We came up with it.
So green
Yeah.
hat. So
Yeah.
what Dorijn just.
I will explain.
Oh yeah, okay,
that we are
perfect.
the green hat. We pretend to be a care group. In the Netherlands, we have many care groups, and that's a network of GP practices that collaborate on organization and financing of care in the region. And this care group decided on a new policy. And this policy entails evening and weekend walk-in hours without appointment in general practice. So patients can walk in, they don't need an appointment to visit the general practice. But for that, additional staff needs to be hired. But there's a general lack of general practitioners and also nurse practitioners in the Netherlands. So the care group has decided to hire basic medical practitioners. And those are doctors. They've received a medical degree, but they've not completed the GP program. So this is an innovation, an idea to solve the problem of patients having to wait too long for a medical appointment. And we would like you to separate and work together in groups, smaller groups, to think about causal insights from the patient's perspective and your assigned head. So each of you is going to be placed in a group, and each group has one hat on. So everybody in your group has one colored hat. So there's going to be a yellow hat group, a green hat group, a red hat group, and a black hat group. And you're going to pretend that you are a patient. And from that perspective, from the patient's perspective, you're going to talk about why, how, for whom, and in what circumstances would this policy, this idea, this innovation that I just discussed, contribute to sustainable and equitable primary care. So first there will be a group discussion and then a plenary discussion. And when you're all together in your groups, the first thing you should do is choose a representative. And this representative is going to wear the blue hat. The blue hat is the manager. So he manages your group discussion and also is responsible for reporting back during the plenary discussion. Rowan, Nienke, and I are the moderators, and we will occasionally visit each group to support your group discussion. But maybe you don't need any support. We're just checking in if everything is going well. And we think that you will be able to do most of it yourself. So then comes when you return after your group discussion. There's a plenary discussion, and for this, when you work with these with the Hats of Bono, there are different sequences of heads that you can use to lead the discussion, and the sequence depends on the aim. So if your aim is to formulate initial ideas, or your aim can be quick feedback or strategic planning, etc., we decided that our aim was solving problems. The problem of waiting times in general practice. We have already given you the facts, so the white hat already did his job basically. And the green hat, that was also us, because we have given you the new idea. So when you return for the plenary discussion, the red hat will share with us what you talked about in your group discussion. Then the yellow hat will respond to that, then the black hat, and then there's also again a green hat. That's not us, but that's one of the groups. You can think about in your group discussion what you can talk about what you think of this idea and in what way it could be improved, or maybe it should be a completely different idea. That's up to you. You are about innovation. Yes,
I will send a link right now to the hats. So with the stick figures with the hats, what they mean, and also with the previous slide with the assignment. So please let me know if the link does not work for you.
Perhaps we can also put those in each room as well. That might
Yeah.
help if
That's a
when
good
you go
idea.
and join, if we can put them in each room so people can follow.
Yeah.
And
I think
that
it's
might be
maybe
helpful.
important to mention, maybe most people might be familiar with breakout rooms, but these are not actual breakout rooms. You have to go into a different team meeting to.
Yeah, don't worry, I'll do all that. Don't worry,
Okay.
We'll sort that.
Yeah.
Don't worry. Yeah,
Because
we're organized and we're prepared
that
for lots
everything-
of things to go wrong, so we're good here.
I think then I'll quit this presentation. Yeah, I'll stop sharing and then we can do this logistical part.
So the next bit, so I'm going to briefly take it back so you get to see me before I have to slope off before my big pitch. So what we're going to do now is I have run proper breakout rooms before and it has been a complete disaster because people couldn't join the breakout rooms. We also can't record breakout rooms, and we know we get a lot of people following the Realist Hub seminars for recording. So actually the really interesting things that you're going to discuss in these rooms, we wouldn't be able to record. So I have set up separate rooms, all with the hat theme. So there are 34 people currently in this chat. So we're looking at between 7 and 8 people in each room. So the first room I have got a list of is the green hat room. I'm going to put the link for that in the chat now. Okay.
Why, how, for whom, and in what circumstances would this policy, the policy is evening and weekend walk-in hours, staffed partly by basic medical practitioners, contribute to sustainable and equitable primary care. So we have green hats and we're supposed to be thinking outside the box.
Yeah, I've just put the link to the handout in the chat that she shared, because that, if anyone hasn't got that, that should be really helpful, I think.
That's helpful.
So presumably we're still wanting to provide evening and weekend provision, because that's the sort of the basic thing that we're trying to achieve, isn't it?
Yeah.
The question is, what are the different ways of doing that?
Yeah, that's a good point, actually, because it sounds like with the green hat, we're supposed to be thinking of ideas on top of this new idea. So
so what can be an alternative way for sustainable, equitable primary care?
Yeah. So
maybe it's not even evening weekend walk-ins, but something else. That's hard.
I suppose an obvious one would be online or phone. So, which is obviously being tried already. So that would be an obvious alternative, which to some extent would be equitable as long as people have got access to internet and phones.
Yeah, because the kind of drop-in online system would be, because just thinking about people who can't leave the house because of whatever reason, that would be improve access. So yeah. Shall I make some notes of everything, because we're going to have to feed this back later, aren't we?
Absolutely. Can we vote for you as our spokesperson, Karen?
Oh no, I shouldn't have said anything. I'm happy to. I have got to leave slightly before 3 o'clock, but I'm sure we will have presented before then. So okay, I'll just write some notes.
Hi,
Ice Girl.
Hi. I was thinking about the pre-triage before the walk-in sessions to, avoid for some waiting times or something like that. So maybe they can fill some kind of a form before come in.
Yeah.
So we can, I mean, the practitioners can know what's the issue, what kind of help they can provide or something like that.
Yeah, brilliant. So a triage system, like some kind of maybe form to fill in.
Before
or,
they walk in, yeah.
Yeah, okay, brilliant.
Thank you for sharing the handout and the link. Sorry, Claire.
I think Karina was first.
Oh, sorry. Yep, that doesn't really matter. But yeah, thanks. So I've actually not long come out of a supervision clinic, a doctorate supervision, with a pharmacy student, and they're doing a realist evaluation of care in pharmacies. So, you know, another option for primary care would be some provision evenings and weekends in pharmacies.
Yeah,
that was, as an allied health professional, that was the line I was going along, was to suggest if we were going to do some triaging. So I think what Isabel said is really important, that if we're looking at some kind of triaging, or dare I say screening, I've just been looking at this myself for my research, that we could have some very basic triaging, and then if we can tell people where they can self-refer, whether it's pharmacy, physiotherapy, occupational therapy, so then we are taking people out of the GP's practice.
Yeah, so something about access to other professionals, AHPs, pharmacists, etc., and also different locations, physical locations, sort of, and signposting. Yeah.
So I was thinking, so one of the problems they raised was staff shortages, staff burnout. So they, so there needs to be a part where we offer something about hiring new practitioners. So they say this partly, you know, staff with basic medical practitioners. It looks like there is a concern around that. So they don't kind of know enough, but we have to hire them anyway because we have staff shortages. So is there a way to offer something like, would, for example, their practice be counted as a training as well, or like something that compensates both? If there is a concern around, you know, these practitioners not being able to provide the care. I don't know, like, because we need to address that because without extra staff being hired, this seems to be a problem. Solved.
Great idea. Should we even think about the health of the practitioners to avoid burnout? So should we be looking at some kind of work-life balance, offering some kind of, I mean, my head has gone off onto community choirs and creative crafting for healthcare professionals so that they can take some time out. They would probably rather have an extra 10 minutes in consultations. That might be of more use.
Yeah.
I was wondering how might continuity of care work in this weekend kind of a thing that's being proposed. Then I might be a patient with something that's ongoing or long term for me. Then do I go back to my GP? So I'm thinking in terms of under what circumstances this kind of service works best and for whom as well. So if I'm someone who has something long term going on for me, then is this, or, you know, then, or will I be confused between, or be signposted between the GP and then going to another service on over the weekend? Sorry, it's possible that this was answered. I may have missed in the presentation.
No, I think that's really good point. So yeah, continuity of care and how, I suppose that the shared records thing is a important thing, isn't it? So yeah, I think it's a really good point.
I agree.
At the very least, it's a note to the GP, isn't it? And if possible, shared records.
I agree about like the sustainability of the system. Like is having weekend walk-in, or evening care, is it sustainable for the healthcare staff? Like even if they are, basic medical practitioners or GPs or consultants, I think it doesn't sound sustainable for the staff who are constantly in the weekend shifts or evening shifts. So I think there needs to be more staff, trained staff, who are able to work, in work hours, standard working hours. So there is I think a dimension of like thinking about migration and skilled migrants and how we integrate different skills, healthcare to society, because aging population is the problem of our decades to come in the Western society. So it's not something that you can fix just by adding more evening weekend shifts. So we need to be, I think, more welcoming and more, how to accredit those healthcare education and experience those people are bringing with them. I don't know, like this is a big, I'm just throwing there, but it's just, I think it's important.
The weekend bit that you said, that actually sounds like it would increase burnout in the population that is there. One more thing, medical education wise, in my context, the government lets each state know how many medical seats they can have. So they'll tell you a different number for doctors, for nurses. So every year, public or private institutions can only have this certain number of graduates. It's to control the kind of specialties that people go into. So maybe one solution could also be increasing the number of people that can actually study, in the particular year. So increasing capacity for training doctors and nurses, that would be a possible solution. And I just wanted to check what your thoughts were. The solution that they provided, it said basic medical practitioners could sort of take the place of GPs. So I was wondering if that means the same thing as task shifting.
I was
Is that
wondering, yeah.
concept?
Hello, everyone.
Hello.
Sorry to interrupt. I just dropped the case description in the chat. Some of you asked for it. Is everything going well? Yeah, you don't need any help?
It's hard.
We just need to know how long we have.
How long you have? Yeah, how long?
I think it will be for
15
or
around 15 minutes, something like that. Yeah. We will go back and forth and see how other rooms are doing, and yeah.
Okay.
Thank you. Good luck.
Did you, Alan Creter, did you want to say something? Sorry, you've got your hand up, and I saw your thing in the chat. You can't put your camera on.
Yeah. No, I just wanted to add and basically follow up on what I said earlier, that I'm trying to wear the hat of a patient and wondering how, really questioning this intervention. Can we ever replace the GP service? Then are we saying that the GP service itself should be available over the weekend? Because there is an out of hours GP service, isn't it, in most places? So how is this different from that out of hours? And even if you go to out of hours service, you ultimately have to go back to your GP, and that's how your problems get solved over a longer period of time. So I'm not sure as a patient how this is it's not even for emergencies, because there's another service for emergencies. So I'm wondering what might be the circumstance when I will go to this service of a weekend GP. I'm not sure. It's probably because I missed the presentation. It could be that.
Yeah, no, it's a great question. I'm just reading it again now, because I think what they mean is this is like, it should be the same as it's not an out of hours emergency service. It's adding more capacity where with drop-ins at evenings and weekends to see a GP about whatever you would go to the GP for. But they are also talking about the basic medical practitioners.
So basic medical practitioners would be serving on those hours.
So is like anybody eligible to call, or does it have to be an emergency that, you know, there's got to be a valid reason why you couldn't go to your GP, or is it something that, you know, a problem that started during the weekend? Is it about that?
You'd need to be really clear, wouldn't you?
Yeah. Is it like, for example, in the UK, there is a locum doctors system. So they are doctors, but they are temporary with fixed contracts, right? But it's not in terms of the difference between their education, but difference about their contracts.
In what she's just posted in the lady has just posted in the chat, it explains in Holland, they're medical practitioners who have received their medical degree but have not completed the GP program instead of locum GPs. So it is,
I don't understand that one though.
A locum is someone usually covering for someone else who does have the qualification. But I just think we need to think outside the box of this GP model, because what it sounds like they're doing is just doing more of the same. Absolutely. I know that there are so many reasons why. I mean, we have to dismantle the model that we've got so that it's not acute care, that it's looking to preventative and maintenance programs for people with disabilities.
Sorry, there's something wrong.
Your voice breaking up.
Yeah. It's probably your headphone.
No, it's not quite frequently. We'll come back and I go like a dog.
Yeah.
Sounds completely fine to me, but it's my superpower.
And one thing, Urshi mentioned the training, so increasing capacity at universities, perhaps for medical training. And can we do some kind of, for example, cross-border engagements for programs that run in different countries, so our medical students can go and be trained. If we can't expand the capacity here, we can still have qualified doctors who also have overseas experience in terms of seeing different patients and experiencing that and then coming back and serving here. Like if we could allow that cross fertilization, we would have qualified doctors.
Yeah.
I'm a migrant myself, so I always think like, why we can't. To me, it's a richness that we could benefit all. So.
Yep. Sorry, I'm not aware of the Dutch context and how it works there, but I'm based in Cardiff in Wales in the UK, and we do have an out-of-hours GP, which is available for a phone, generally for a telephone-based consultation during weekends and late in the evenings. But they do see you face-to-face as well if it's required, if it's necessary. So this thing is sounding similar, very similar to me. And then obviously they are able to give you some immediate relief advice or even prescriptions based on your condition. And then then obviously you go back to your GP during the weekdays. So to me, this is sounding very similar. And then as a user of this service for my son, sometimes I need to contact the out of hours GP, especially for my son. For example, there was an ear infection. It felt pretty urgent, but it was not an emergency that I didn't need to take him to an emergency. I called them and they agreed to see him in person and examine him and give medication as needed. So but as a user of this service, I would say the only issue is the disconnect from the overall GP practice. It's something outside of that sits outside of the GP practice. So for me as a user, ideal would be that the same GP practice is extended to the weekend and out of hours during the weekdays, even if it is even if it is trainee GPs doing those hours, that's absolutely fine, but linked to my local GP practice. So I'm not thinking out of the box, but really definitely wearing the hat of a patient.
Yeah, definitely. I think that's I think I've got a bit confused with which hat we're wearing in this exercise now, because the hats
we're
are
looking
all...
for alternatives.
I think the
aren't we?
prompt
Yeah.
said.
I
Did
think
the
that might be
prompt
from a
say that?
patient perspective,
Oh, the prompt did say that patient perspective.
Patient perspective, really? I thought we were thinking from all perspectives with a out of the box hat.
No,
I'm so confused.
Elkim, I'm reading from what you shared in the chat.
In the presentation, they mentioned think about the patient, but in what they've just posted in the chat, it says it must balance patients' rights to timely access as well as healthcare staff and sustainability. So I think those are two very different things if we look at the entire thing.
Opposite, isn't it?
Yeah. I think whatever we go back with, it'll be fine. It's all a good exercise in thinking, isn't it? Yeah. I've got a really long list of different ideas, so I apologize if I haven't captured everything exactly, but
it's great.
I think they're from a sort of a group of different perspectives, aren't they? There's the providing alternative care and different ideas for the care. Then there's the providing different staff. So whether that's training or task shifting or whether it's training people and bringing people in from other countries, then that's kind of another grouping. And is there another group? Can anybody think of another group there?
Yeah, but I agree with what Claire said earlier about systemic change. Not doing the scaled up version of the same thing that is not sustainable, but finding different ways of caring different groups of people. As you've said, if people are overworked, not only in healthcare sector but every sector, then we are not able to care for each other and elderly. So even like decreasing number of days of work for everyone would shift and enhance our quality of lives for everyone. So it's just
forcing employers to allow their staff to have time off to go for appointments.
Yeah, absolutely.
Paid.
Absolutely. Absolutely. So that I agree. Probably like during daytimes, people are not able to go. So it's not only, I guess, the unavailability of the service itself, but the time wise, exactly. Let's put it in there, like allow people to go to appointments so they don't have to look for a weekend shift.
Yeah, that's a really good way of flipping it around.
Yeah. But also, if I was an elderly patient with lots of comorbidities, would I find it more difficult to get out in the evening? Would the transport options be different? So I'm just playing, I've probably put the black hat on now and I'm just playing devil's advocate, but there's so many different ways of looking at it, aren't there? And I would love to see that community hub and prevention, meaning that not so many people were wanting to call a doctor and see a doctor because there were other options, or they didn't have such acute disease and they didn't have so many multimorbidities.
I agree with Claire. Because of that, I was talking about the travel support for people who cannot travel alone, especially evening hours or something like that, and also providing some kind of a childcare support for carers who can, accompany the person who have kind of mobility issues or something like that, or maybe the cognitive issues, because in the evening it's getting worse, as you know, if you have dementia or something like that. So I agree with Claire, definitely.
Yeah, that's all such a good point. It's all this theme of flipping it to enable more people to come during the day rather than putting more out of hours. So yeah, that's such brilliant points.
And I think, Claire, as well, you were making a public health, almost like a public health kind of point, weren't you, about prevention?
Yeah, it's like a systemic change, kind of shifting the way we, like, not from scarcity perspective, but there's abundance, but we need to see it as abundance. We are seeking for care only from GPs, only from at certain hours, and it's not sustainable.
Ban McDonald's. There we are. That's the
Amen.
solve everything. Pardon?
And enforce exercise, movement in some form.
Yeah.
I don't want to call it exercise because that makes me think, ooh, don't want to do that.
Ban cars and McDonald's. There we are. That's it.
But then you have an increase in like sports injuries and leg sprains.
Well, then all go to the physios then, so they won't. Then
No,
the
that's
GPs
true.
will be able to have a bit of quiet time.
Yeah.
What about, dare I ask this question, but I'm going to anyway. What do we think about the potential for AI to help out in this situation? I know, and I thought that was a bit brave.
That's a big one.
Or robots, right? Like,
I think AI's got interesting applications in admin. So like maybe AI's got roles in like coordinating
triaging,
triaging or like arranging appointment slots and things like that in the most time effective way. I think there's really potential applications in that.
Yeah, and I think in providing supportive information. So if you've seen a healthcare professional, then there can be more direction to access. Self-management side of things.
Because I self-referred myself to a service a while ago with an AI chatbot, and it was actually a really good experience. I felt like I had a lot nicer experience than trying to phone up, and I wasn't getting actual advice, but I was being signposted to different services, and it was actually really effective. So yeah.
I feel I need a disclaimer now because I just agree. I think that's the kind of experience I'm thinking of, Caroline, where you're being signposted by AI. I definitely think we do need some kind of personal interaction. I'm not sure that it has to be with a qualified doctor, but it needs to be with someone who can help you in whichever, for whatever situation you find yourself in.
Yeah, absolutely.
Yeah, I agree.
I had an interesting conversation recently with there was a physician's associate. I've forgotten the job title, but she was saying apparently at the moment in the UK there are GPs who are out of work because although it's not that there's not enough GPs, it's that there's not enough funding for GP jobs. So there are GPs who are having to go back and work as an SHO level because they're qualified as a GP, but there's no jobs for them, which I hadn't realised. So
I think you've just hit the nail on the head for me, Caroline. That's where that is the basic problem. There are GPs, there is the need, and there's an understanding that there's a huge gap. There's a need, but there is no funding.
Yeah.
Which is where the task shifting comes in.
Yes. We need to go back to the main room.
Play devil's advocate, don't we, with the black hat on, and trying to sort of come up with ideas and theories about why it might work, why it might not work, or why it might, or alternative solutions.
So just so I can be sure that I understood the proposal in full, because I'm not sure I did, but it's about providing out of hours appointments on a kind of first come first serve basis. People turn up at the clinic, but it's the clinics that are provided by doctors but not necessarily qualified GPs. Is that all right?
Yes, I think you understood that correct. I think the role that they were describing, it's called something different in every country. In Canada, it's called a physician's assistant, or PA. I'm not sure if that sounds familiar. It's actually something we don't universally have in Canada. I'm not sure if that's true in the countries that you're from. That's what makes it quite novel here, at least.
I'm in the UK, and we are just starting, or kind of over the last 10 years or so, we're starting to get physician associates. But that isn't, I mean, I don't know, I might be wrong, but that isn't what I'd understood they described in this intervention. I thought they were saying there were maybe people who did have a medical degree but hadn't gone through the GP training pathway.
Okay.
Mm.
To
But I
make
mean, it
more
could,
kind
it could be sort of advanced.
Is that a trainee?
Yeah, so here they'd be called, well, now they used to be called junior doctors, and now they're called resident doctors.
Oh, okay. I wonder if it could be both. They're quite different roles. So I guess that feeds into our devil's advocate is the clarity part. Yeah.
Yeah, absolutely, because there's been issues in the UK with people feeling concerned that they aren't receiving the right care from physician associates. So even if that isn't what's being used here, I suppose there's a risk that people would maybe feel they're not getting sufficient care if it's not from a qualified GP, and not feeling sure if they're being seen by a doctor or by another healthcare professional.
So I guess that could lead, for example, in the case of this proposed solution, it could lead to people not taking up the appointments because they don't feel confident that they'll get the right care. Or it could lead to people take up the appointments, but kind of complaints come up about the quality of care, which could have a whole lot of unintended effects on like the morale of the practitioners, and could create like a whole big blob of work within the system as well. So I guess that's implications.
I also wonder with that, like, I thought there might be that sense of overwhelm, and if they're not, depending on what level of experience you've got, if they're newly qualified resident doctors, would they be overwhelmed with that sort of influx of people? It's already hard enough when you've got a busy waiting room with busy clinics to deal with that. But if you've got an unregulated version of that, where it comes off sit and wait, because it used to be in the UK, used to have a number of sit and wait appointments. But that was even when we used to have it in the UK, as that was regulated about we used to have a certain number of sit and wait appointments, whereas this seems to be open doors that as many can come in as they would need to.
But surely there's an element of sort of, if you're not that desperate, you might sort of decide to leave anyway.
Yeah, but then look at A&E. Look at the number of people that go to A&E that don't, like if you look at the A&E in the UK, like the number of people that go to A&E that don't really need to go to A&E. Is it going to be sort of a similar like?
Depends on the waiting time, presumably.
But people wait 4 hours in A&E when they don't need to be in A&E. I don't know. I'm just again playing devil's advocate here.
And that's what you're supposed to do.
I've done research on sexual health services, which a bit less so now, but traditionally they've also kind of operated in a first come, first served basis. And yeah, it's not necessarily an efficient way to to see people aren't being triaged according to their needs. And at least that's happening in A&E, so people have an idea of, well, staff have an idea of who's there, and patients have an idea of how long they're going to wait. And there's a risk of kind of being worried, well, we have the capacity to come to appointments, taking up space with people who might need it on a medical basis. Yeah.
I wonder if there's sort of like a level of abuse when people go unnecessarily. Because sometimes, like, we have this thing like we go, oh, we don't really need to go to the doctors because it's not that bad, and then within a couple of days it sort of it solves itself. Whether just because there's availability in some respects, people will use it, but actually they probably don't need to see a doctor. So we'll just sit there now, overwhelm the system.
Yeah, and when you said abuse, I was thinking of a different kind of abuse, which is, you know, that when people are waiting for a long period, they're more likely to become frustrated and so on. And then those kind of being abusive towards people working at the clinic or whatever is more likely. And again, that could lead to forms of burnout and, you know, all of the same kinds of problems as this is supposed to be the solution to. So, yeah.
And could there be an element of role creep so that you end up with sort of nurses doing the sort of the GP job?
Sorry, I think I missed the first part of what you said there.
So, could there be an element of role creep where you end up with sort of nurses doing the alleged GP job?
Yeah, especially if you have experienced nurses who have worked in general practice for years, who might, in some instances, know more than a newly qualified doctor who isn't trained in GP care. So yeah, exactly what you're saying, Julie. I think that's a risk.
One thing that stood out to me is that if it's these physician assistants or associates or medical residents who sort of automatically get on the weekend and evening shift, it doesn't account for potential inequities that an intersectionality that they might have. Like, what if they themselves have children or serve in a caregiving role and disruptions to their relationships and work-life balance? It might disproportionately burden them with a lot of that work, unless that is a consideration. The first thing that actually popped in my mind when I saw that was, oh, that's not going to work with people who themselves also are working professionals who have these roles.
And does it depend on what time of day that you're sort of offering these walk-in appointments? So whether it's sort of evening or during the day, during sort of surgery hours, weekends?
Isn't that an important point that I think about that? Like, if you think about the UK, we do the 8 o'clock mad rush for appointments versus, say, an evening with the mad rush to get treated before the end of the day. That could potentially have an impact on the number of people that attend as well.
Can you tell me a little more about that so I can record it?
So in the UK, to get a doctor's appointment at the moment, you have to basically phone up at 8 o'clock, and there's a certain number of appointments, and it's like, you are 58th in the queue. It tends to be my experience. And so you wait in the queue to find out there's no appointments left for that day. So depending on when you need to get in, like, obviously that's not going to have that issue in terms of voting for appointment, but if you're 58th in the queue, are you going to have 58 in the queue in the doctors?
Access to other services on evenings and weekends. So another thought was, even if they do get these, because it explicitly says that they're going to open up appointments on evening and weekend for walk-ins, first come, first serve. Our staff partly by these basic medical practitioners. But what if things like laboratory services or diagnostic services aren't open until the subsequent Monday, 8 a.m. anyway? Does that not create more the same funnel? I don't know how it works everywhere.
And who's going to fund these extra staff?
And I wonder whether the sort of these basic practitioners will have whatever they need to be able to kind of respond to every situation.
You're muted, Tamerlane.
Oh.
No, I could hear you, Tamerlane.
I could hear you. Yeah.
Sorry, can you hear me now, Denise? No. Oh dear. Okay, someone else try and talk, and let's just make sure Denise can hear others at least. I can write in the chat.
Okay. Can you hear me, Denise?
Oh dear.
Not sure.
Well, I was just thinking, yeah, will unqualified doctors sort of have the, I don't know what you would call it, but kind of the permission or the whatever it is that you need to be like entitled to refer someone to particular other services or make certain decisions about what this appears to be and what should happen next. So will they be kind of prepared for every situation? And I was also thinking if there was like a legal challenge, like what would the legal position be of these individuals who have been placed in this position not fully qualified, and also of the patients who have been given access to them? Yeah, like what would that look like, these sort of potential legal issues?
Mhm.
And I was
Sorry,
thinking,
I missed the bit from when I was talking about the laboratory and diagnostic too just now, but it sounds like you're talking about similar of like with the legal, like so if there was a mistake or if there's errors or if there was other challenges that came up during that time, what supports or services would be available? Did I
Yeah, like,
understand
well,
that?
what are the implications both for the junior doctors or whatever and for the patients in if a legal issue came up? And then I think the other one was just, would these sort of basic practitioners have the same ability to make decisions about like where people are referred to next? Like, oh, this looks like cancer or whatever, so now I'm going to refer you to whatever. Are they kind of allowed to do that? Because I imagine that you have to qualify as a GP in order to be able to do X, Y, and Z. So what happens when they aren't able to? Are they then given that power? They can't, and what will the implications be?
I'm thinking as well, thinking about this outside of the UK context where we don't pay for healthcare. If we are in America or somewhere else where you pay for your healthcare, would people want to pay to see somebody who could potentially be unqualified for what wanting to see them for?
Yeah, and how would it be costed against an appointment with a qualified GP out of hours versus normal hours? Yeah, it seems complicated.
Mm.
Gosh, being a black card is it's kind of hard. Oh my gosh. It's so like clearly it's important.
I'm also wondering when it comes to money issues, given that these sort of junior professionals will be being asked to work in kind of unsocial hours, will that mean that they would be given sort of overtime rate of pay? How would that impact on the pay they would be offered? Yeah, and what are the implications of whether they're given additional pay or not, both on the affordability and on kind of the nature of that form of employment, how sustainable it is to really be a doctor in those circumstances.
And would it count towards their career progression in the way their normal contracted work would, or would they be expected to do it as kind of add-on out of hours?
Well, I think you've got to have to think about how the organisation is structured as well, because it's sort of if the sort of
Hello,
yes.
sorry to interrupt.
Oh, yeah.
I just wanted to share the case description with you and ask you how you are doing.
Oh, we're doing we are having a hard time, but we're doing a great job as a black hat, I believe.
Yeah, okay, no, that sounds good.
Yes,
it's hard,
yes,
but
and
you're
we
doing
feel
great.
a little terrible about it, but it's raising some very important
You feel terrible because
considerations.
you are so negative, or?
I think so. I think when we see the balance with everybody, it'll feel probably a lot better.
Yeah.
But yes,
yeah.
clearly
Yeah,
some very
I think
important
so
things
too.
are coming up.
Okay. Well, you have about yeah, a little less than 10 minutes, I would say. So somebody will pick you up
Okay.
in about 8 minutes or so. Yes?
Okay.
Okay, good luck.
Wonderful.
Thanks.
Thank you.
Yeah, I think
Let's
there's
take
also the thing
maybe
about sort of the organizational structure. So even if people
yeah.
don't necessarily believe in what they're doing, does that make them do a better job or a poorer job?
That's interesting. Can you speak a bit more to that? I think that's something we could probably expand on.
Yeah, I think it sort of comes down to sort of individual values as well. It's that maybe they think that they're out of their depth, so therefore they are out of their depth, or whether the sort of the organizational structure or culture is ready for them to do that.
Right. So if they have like the supporting infrastructure or
Yeah.
prerequisites in place to even do this, or if they feel like they're sort of, what is it, juggling?
Yeah.
Okay.
Yeah.
I'm just reading over the description of the intervention to see if there's anything I hadn't thought about. And I mean, we have kind of talked about the equity of the out of hours appointments already, but it struck me again that they've said the big concerns are among young families with sick children and older adults. And those are probably the populations who it will be most difficult to come to an evening appointment, especially, and potentially weekends as well. So it's actually, unless it was about getting other patients to attend these appointments and freeing up the daytime ones for, that's not really our job as Black Hats to say that, but yeah, I think it's potentially kind of a solution for the wrong problem. It's not, it's kind of offering the least to the people who need it most. And also, again, we've touched on this in different ways, but if it's older patients with complex health needs, again, and children, those are probably the patients you'd want to be seen by the most qualified and experienced practitioners rather than those with the least experience.
That's it. I was thinking the same thing as I was checking this, and I'm really glad you brought this up because I don't know how, again, it works outside of Canada, but it's exactly as you said. Like most people who've got chronic healthcare, especially multi-morbidity or children, automatically get kind of, I don't know, they kind of get like shifted over to somebody else, which creates a bit of a funnel anyway. So unless like the burden is alleviated because other people move into these weekends and evenings, as you were saying, it doesn't actually serve them, at least not directly.
To me, in some ways, an evening and weekend would be most beneficial to the working people when they can go outside of work. Like in some ways, like a lot of the time you have to try and juggle, you take a doctor's appointment, you can take a doctor's appointment and you'll take whatever time you need, but sometimes you can't, like for routine appointments, surely things like that would be more beneficial to do then. I don't know, I feel like it needs a bit of a shift in the way it's been done to make the case of like, well, the emergencies need to come in at a different time when the need's there, rather than, I get there's probably a need on a weekend when there isn't a doctor's open. Maybe that's what they're trying to say, but just in my head, I'm just thinking those sort of times are probably mostly to people who work.
So going to the part, the decision must balance patients' right to timely access with the well-being of healthcare staff and the sustainability of the healthcare system. The bottom line is what it sounds like right now is, as is the design, we are raising points that the current solution doesn't, in fact, presently support those. or at least not completely, without giving something else up.
There's an element, isn't it, that if we're proposing this, then is it going to benefit the welfare of the staff? Because it sounds as if you're just going to put a massive burden on just somebody else. It might benefit some, but maybe not others. And if they're newly qualified, we're assuming they're newly qualified, don't they need to have a certain level of supervision and newly qualified? I know when we've been doing junior, like senior, well, what used to be junior doctors, they used to have a certain level of consultant observation in some of the clinics I used to work in. So there has to be some level of additional staff being on at the same time. So they said that in the end, then they'll just refer them to those anyway. So you might have one person supervising 4 people, but they'll get the big workload.
Yes, and on that note, what of documentation? Does it create another documentation layer, or is the infrastructure already in place for them to debrief staff? Like on Monday, for instance, when suddenly they're bringing in 20 patients who came up on the weekend. I don't know how that works. If there's actually structure in place for that already. I know Monday mornings are terrible for my GP, who's just like this, because yeah, it's already hard.
I think we've done a comprehensive job of tearing that to shreds.
Yes. What I'm doing now is I'm just sort of structuring things by sort of consolidating it by the theme area. I think it's time for us to go back into the room now. But I hope I did it justice. I'll share
Yeah,
all the notes wherever
I'm
they
sure
tell
you
us
did.
to. Yeah.
Yeah, I'm conscious that I volunteered you, and yeah, really appreciate it.
And in what circumstances would this policy, so evening and weekend walk-in hours staffed partly by basic medical practitioners, contribute to sustainable and equitable primary care?
I'm going to try and frame this positively. For people who are not very sick, but how would you know? That's I'm going into the green hat, aren't I? But yeah, for people who have got minor illnesses, minor ailments.
I think this could have a lot of advantages for people who work in jobs that are 9 to 5. So if you work shifts or you've got a job where you can't leave your job to go to a medical appointment, it's going to be much easier for you to access an appointment on an evening or a weekend. So for people in jobs with low flexibility.
And for somebody who thinks it's a minor ailment, but actually it turns out to be something more serious, perhaps they'll be triaged more quickly because they'll be able to get an appointment more quickly than they otherwise would if this service wasn't there.
Yeah.
And was it walk-ins as well, so you don't need to kind of have that early morning ring up to, which also takes time out of your day to kind of book an appointment. You can just go as soon as you need it.
I suppose it's positive for the basic practitioners as well. I think they say they have their medical degree but not yet GP training. That will give them a lot of experience for their GP training if they go down that path.
That's a nice point. You're all really good yellow hatters. I keep thinking of negative things and I don't know.
Did it also mention weekends? You could go on weekends, did it?
Yes.
Yeah. That would probably relieve a lot of the burden off A&E, wouldn't it? Because if you can't get to a GP, then you have to go to A&E on the weekend. And usually it's not well, not always, but in that respect, it wouldn't be emergency, would it? It's just because you can't get into your GP, so that might help. But I think, are we supposed to be talking from the perspective of the patient rather than, yeah.
There's a question
I think
there
perhaps
about
also,
Sorry.
I think also maybe this would help for patients who work like night shifts, for example, who have like a different day-night rhythm. But what were you going to say, Jane? Sorry.
Oh, just that in the question it talks about equity and sustainability. So I'm guessing, I'm just trying to think how evenings and weekends, and I suppose it's that point, isn't it? If it's for people who work different shift patterns or jobs during the day, or kids to look after.
It would also free up potentially appointments for people that really do need to see their GP during the day. If the pressure is relieved of the main service, that would be a positive for those people.
Yeah, because we know, don't we, that people who benefit the most from continuity of care are people with long-term conditions, and having that continuity is really important.
Yeah,
I think they mentioned like aging population as well, so it might be people that are sort of retired that then could take those during the day appointments. So then it kind of matches people's needs a bit better.
I guess it also depends on what you mean by equity, because if you're creating a slightly different system, does it then make the two systems unequal? So if I'm available to go in the evening, then I can just drop by. But actually, if I'm not available and I have to go in the day, then I have to go through the whole system as usual, ringing up. I don't know about you, but ringing up at 8:30 in the morning for half an hour, being 17th in the row, and then getting cut off because there are no appointments left. So actually, would it create an inequality between people that have to attend in the day and people that could attend the more flexible clinic?
You've put the black hat on.
Yeah.
Oh, sorry, put the black hat on.
We were all thinking that, Genevieve.
Is this a system though? It's not intended to replace those GP appointments, but be a sort of extra layer, if you like, whereas the alternative isn't going to the GP. The alternative might be for these people doing nothing. So it's sort of an extra part. I'm imagining in my yellow hat, I'm really trying with this yellow hat, that this service will escalate to the GP where necessary. So it is almost acting like a triage service in itself. So the alternative would kind of be nothing rather than a GP appointment.
Yeah, or maybe a 2 or 3 week wait for an appointment.
Yeah.
Or as somebody else said, using a different part of the service like A&E or out of hours. But they, sorry to be negative, I'm really trying to sit on it. But there is, like, we all know in reality how A&E works. I mean, it's like a tap that isn't ever going to be turned off. So in effect, I can't imagine any world where those additional out of hours appointments will free up any daytime appointments. So but that's being negative, sorry. Just from an equity, somebody picked up the equity thing. So from an equity point of view, I think it will be like two different, each kind of option will favour some people and disfavour other people. But maybe that's a good thing, because if you've got the daytime, have to ring at 8 o'clock, have to be really on it in terms of, getting that appointment really. And if you're not in that group, then actually the other system, the other service might suit you much better. So that would be more equitable, wouldn't it? Because you're providing options for the two different groups of people. Oh, there we go, positive.
Yeah. So there'd be people with like homeless people who couldn't do that 8:30 phone call, who might find a walk-in service more equitable. So and there'd be other groups as well, people who have hearing impairment who find it hard to talk on the phone. There'd be lots of groups who perhaps that could advantage, wouldn't it? The other thing I thought of was
go on.
I was just going to say from a patient perspective, it may be good for anxiety because you don't have to sit at home and worry about your problem. You can go in the middle of the night on a Saturday morning and you can go straight away and see somebody and get it sorted out. So from a patient perspective, that would probably be quite nice, that you don't have to, inconvenience yourself by, waiting or worrying for a long time.
I just wonder if there's anyone on the call that is familiar with the health service in the Netherlands or is from the Netherlands. I think because we're talking in a very kind of England or UK context about the waits and the calls. I don't even know if there's a cost to services like this in the Netherlands or anything like that. I just wondered if anyone knew.
There isn't.
it's covered by your basic insurance.
So there wouldn't necessarily be a cost difference even for insurance between this service and a GP appointment?
No, I don't think so, because if you just go to a regular GP appointment, like that's, I'm not entirely sure how it works, but I don't pay for it. That's how I know.
I thought being cheaper might be one of the advantages, but yeah, it's not. Thanks.
Yeah.
My understanding is that the system is as close to UK primary care, so they're very similarly organised systems, I think.
Yeah, no, I've done comparative studies looking at the Netherlands, and they are quite similar.
Yeah.
Okay. Yeah, I don't work in health, so I've got no idea. Sorry.
Yeah, when I visited there, I was like, oh, wow, this is really good. You should move here. You should really move. It's better than what we do anyway.
I guess the key thing we're saying is the flexibility, isn't it? Patient flexibility. It's attuned to what the patient wants. Hopefully, I mean, there may be other things as well that patients want that haven't necessarily been found out, but it would seem that it covers a number of bases, doesn't it?
Yeah,
I might be
giving
wrong,
people
but one thing-
options. Yeah, one thing that I was impressed by was, although things might have changed, I might be thinking of it wrongly, that you can go and have say you find a lump in your breast, and you can go and get a scan without having to go to your GP first, because you would do that unless you'd found something. You know, you can just go. It takes out that kind of chase. Yeah,
that's amazing.
So something like that, you know, like you were saying, Freya, instead of sitting worrying about it, you find a lump, you just want it seen immediately, don't you? So to be able to,
we're almost there in Scotland.
Oh wow!
So you can ring your GP surgery and say, like, you know, you've got a concern about your breast, and they'll put you straight through to the breast assessment clinic.
Yeah.
But yeah,
it does seem such a waste, doesn't it, to have to go and then, you know, waste the GP time. And then
Very gatekeepery, isn't it, in the UK?
yeah. And that is changing, I think, slowly, but because it's having to.
There's a sort of thrust of our argument here then that this service isn't about comparing this service with getting GP appointments. It's about comparing getting this service with everything we've said about not being able to get GP appointments, about having to wait a long time for a GP appointment. That's how we frame it as a positive. We're not looking at the level of expertise from the person that you're seeing, but what the alternative might be if you work long hours or you're unable to access GP. It does sound quite positive when we think of it like that.
Actually being able to see a GP on the day. When was that? Last 1985, I think.
do we need to think of it in terms of CMOs? Realist angle in.
I guess that comes next, presumably with the 6 hats approach. I don't know.
Yeah, possibly.
I guess it comes into maybe whether you feel that this service would work for the patient, or whether you feel it would work for the service, because obviously it's usually the service that instigates it. The patient has to access it in order for the service to be useful. So there are several perspectives there, perhaps. So I guess, I mean, I prefer if-then statements, if-then because anyway statements. I don't know about yourselves, rather than CMOs.
Oh, definitely if, yeah.
It's a bit more logical, isn't it? So if you have a clinic that opens outside normal hours, then patients will attend because, and that becomes your mechanism. Just a thought.
Yeah, and you can start by looking at those people who are particularly disadvantaged by the kind of 9 to 5 having to pre-book kind of system. And then those people are those that might be more likely to benefit from this new service. I suppose if you don't have the capacity or ability or whatever to, you know, call at 8 in the morning repeatedly to get yourself an appointment in 3 weeks' time, then it could be. Or if you can't wait 2 weeks because you certainly feel it's more urgent than that, then that's where, because we were asked to only see it from the patient's perspective, that's where you kind of really need to see it more holistically, isn't it? And bring in the services perspective and the whole wider kind of health system there, you know, because actually this does have the potential to have an impact on A&E, as someone else pointed out, or whatever. Difficult to measure, probably, but.
Yeah. And I wonder about, you know, we were talking about different groups and what impact it in terms of men. Do men not access services, you know, of a certain age for different reasons? And would this be, you know, having more of an open door policy, would that encourage people to go?
Hello, everyone. Sorry to interrupt. I just shared the case description. Maybe that might still be useful. I don't know. How are you all doing?
Fine. We found it hard initially to put the yellow hat on and to discard the black hat.
Yeah, people tend to be more negative than positive. So, but you have the yellow hat on now?
Yeah.
Yeah. Okay. Great. Yeah. So we have about 15 minutes in total, or still left. Yeah. And then so we will come back to ask you to return to the main room at some point. Yes. Good luck.
Thank you.
We've got another 15 minutes in us.
Do we want to get all our green hat stuff off our
I don't feel that positive.
Shall I go make us all a nice cup of tea? A piece of cake?
Maybe. I
That would be
wonder
nice.
if we do talk about some of the negatives, we can try and find positive in the things that we've all just scanned that and gone, yeah, I can see, oh, that's not going to work for loads of people in loads of ways. But it might be worth just talking about the things that we're kind of trying to sit on to see if we can come up with any positives or any solutions.
Yeah.
Erica, do you want to go and let it?
Oh. I initially thought that people with agency, so bullshit impatient people, will benefit from this new service because they'll make sure they're bloody well there at 5 o'clock bang on. I don't know. But then the same could be said for the existing services where they're phoning up at 8 o'clock in the morning. It's just that I suppose they might be the people who are less likely. I'm not waiting 2 weeks for an appointment, even though they kind of know that it's not urgent. They just don't want to wait 2 weeks. So they might be the one that's there at 5 o'clock, kind of almost taking up space. Because there are undeniably lots of appointments that can legitimately wait 2 weeks, 3 weeks. It's just that people are frustrated because they expect to see somebody now. So I don't know. That was my initial kind of thought.
Yeah.
I once had a
Sorry, go on, Genevieve.
So I once had a practice where you would had to ring in order to get an appointment within 2 weeks, but they couldn't give you an appointment longer than 2 weeks. So you just ended up not bothering making an appointment in the end. So there was a lot of frustration around that. And I think that someone mentioned the anxiety that is involved in, you know, getting this appointment, you know, maybe having to ring at 8 o'clock before you go to work and trying to get an appointment, and the anxiety around actually getting an appointment, you're actually getting rid of it with this, maybe. So that's a big plus, I think. Probably people's situations are actually exacerbated by the appointment system as it currently stands.
Yeah. I wonder if that's also can extend into the relationship that the person has with a healthcare provider, that actually when people feel there's a big barrier to accessing the service, they sort of attending the appointment feeling quite annoyed already that like I've had to wait 2 weeks, or, you know, quite negative about it. Whereas maybe you go in feeling more satisfied at the beginning and perhaps in a better place to have a good, productive conversation if you've just got this open sort of access, because it doesn't create that sort of that annoyance at the system.
When was the last time you went anywhere and didn't see a sign up saying violence or abusive language will not be tolerated? You never saw that 5 years ago. You never saw that, did you?
Yeah.
And part of it, I think, is right. It's this frustration that people can't get an appointment. They can't talk to someone. They can't get any resolution about something. So they're automatically going in there being annoyed to start off with, which doesn't help their health and doesn't help the relationship with the medical professional or the medical professional's well-being, because we're talking about that. We're talking about the well-being of healthcare staff as well.
And then also maybe in extension of what Freya just mentioned, I perhaps can imagine that people right now, they are very like motivated to get an appointment, and the people that will be there like at 5 o'clock when the doors open, while that's not really necessary, maybe if the system would change in such a way that this is accessible, then they would feel like healthcare is accessible to them, and they don't feel such a need to actually be there at 5 o'clock, because they know that they can show up whenever and they can have that appointment. But they also know that the initial like survey thing show that it is not as urgent as they think that it is, so it can genuinely wait 2 weeks, and maybe that like kind of gives them, it calms them down, and can cause them to then eventually, once they realize that the system has changed in such a way, not ask such a thing of the healthcare system.
Yeah, the hope would be that you get less of that 8 a.m. rush, because everybody understands that, well, you can access healthcare 24 hours now, so you don't need to concentrate it all in this tiny period.
But my initial thought when I saw it was the worry about a 2-tier service. Go back to what you were saying, Jane, about sort of naming the negatives to try and think of positives, and that I think some of the discussion we've had about the alternative being nothing has helped that, but actually it would alarm me a bit. Are we going to have, if not a 2-tier service, an impression of a 2-tier service, that patients think that they are speaking to the real GPs during the day and the unqualified, not as good staff in the evening? Will that create a tension there, I wonder?
Well, you can see what's happened with the physicians associates, and I'm not saying that they're physicians associates, but I think the difficulty is if you're self-assessing your symptoms, then we know that men do that differently to women. You've got the worry, well, people think, oh, it's nothing, and put it to one side, and then I may be going, so there's a real danger there if you're not being seen by a qualified, and I think it undermines what it means to be a GP. Which is in a profession that already feels quite undermined as well. And then I noticed it says instead of locum GPs. So is a positive of having this is that it puts more, well, I don't know whether it would be. It would certainly be from a financial perspective, putting locums out of a job if you don't need so many locums or doctors going into that way of working. But
a positive could be that patients benefit from the savings that the practices are making by not having to spend on locums.
Yeah,
that is actually a good positive.
Yeah,
I do wonder about the sustainability of it in terms of, I don't think the expressed need is going to reduce. So, I don't think there will. I think this new service laid on the existing service will very quickly fill up and overfill, and then what do you do? So I just wonder whether this is the best solution. That's a different hat, is it? It's green or something, isn't it? But actually there's lots of innovation. There has been, certainly, especially prompted by COVID, or perhaps exacerbated by COVID. There's lots of innovation around appointment booking. Like, I know that it's gone digital a lot, and then you've got other problems around digital inequalities and so on, but there's innovations there. There's certainly innovations in triaging, so receptionists or general practice reception staff are now so much more sophisticated. They are triagers in many ways. So all of that has changed the context so much. So maybe it's innovation there that could create a more sustainable solution to the problem, or way of managing the problem, than adding on another service with a workforce that's already very stretched and burnt out, or at least in the UK. That is probably never going to be sustainable. It's not going to reduce, not realistically. I can't see it reducing capacity anywhere else, and I can't see it ever getting to a point where they don't have too many patients per appointments. Maybe I'm just being really negative. Sorry, that's my black cat.
It's how we're trained though, isn't it?
But this is what you'd explore in the evaluation, isn't it? So that's all good. This is what, you know, creates those evaluation questions and the initial theories.
You notice there's a campaign now called Ask for a Doctor in response to the physicians, and you know, the R's, you know, replacing GPs and what it's done to the workforce, and you've got all these GPs that are out of work. Is there because on the one hand you hear about a workforce that's burnt out, and then when we try and find sustainable solutions like this, then there's a backlash, isn't there? So there's a tension there, isn't there, in terms of boundary encroachment and professional identity, and then you've got sustainable solutions, and how do they kind of butt up against those identities? It's tricky.
Yeah, because it'd be interesting to know the GP's perspectives on using untrained GPs for the evening and weekend appointments, how they would feel about that. Whereas we do have lots of examples of advanced practitioners, you know, and again, triaging to certain things. So in many cases, GPs aren't the most useful, sensible person for someone to go and see. You can just punt them straight through to the breast assessment clinic, or you can punt them through to a specialist mental health nurse or whatever. So, you know, it's not all about the GP.
If there are people with medical degrees that would go on to do their GP qualification, I think that's what I said the system was. So would it detract from their sort of motivation to go on and qualify as a GP if they were able to work as a GP through this system?
That's a good question, but presumably they wouldn't be trainees for long. I mean, they would just be like registrars, wouldn't they? So they'd just be in that period where. But then we use registrars in the system at the moment. I don't know enough about how it works. But that's a good question.
Me neither.
Shall we return? I'll try my best to summarise.
Yeah, should we each choose a kind of a patient persona in our heads to feel from or for, or just generally reflect?
I think they were just saying kind of go with your gut feeling in relation to what's being proposed and how it will make you feel.
Yeah, I guess my immediate response was maybe slight concern because it said that the GP hadn't done full training. So if I've got an emergency out of hours, and particularly if it was a child, so there's context. If I've got a sick child in particular, I want them to be seen by someone experienced. So I might feel a bit anxious about that.
And I was thinking about, so they talked about elderly patients with multiple chronic conditions, and I know that in our area there are issues around the pensioners' subsidy for transport only being during certain hours of the day, and actually that evenings is not a good time to add on. So maybe this wouldn't help alleviate the burden unless they could shift the people who are very proactive and good at getting those daytime appointments.
So what feelings does that align to?
I suppose the feeling might be frustration. It's like, yes, you say you're setting up this inclusive and helpful policy, but it's still keeping me out. Yeah.
So feelings of exclusion, frustration, isolation, if you can't get on the transport.
Yeah, or if you need somebody to go with you and getting them to go along during those times that tend to be kind of off hours for people who want to do their own things at those times.
Can I offer a positive thing?
Yeah.
You know, when they say aging population, what is there a particular age range they're thinking about? Because I was thinking it might be kind of make people feel a bit less worried if they know they do have the opportunity to go later in the evening if they are still at work. because I know a lot of people are having to work a lot longer now. So that's definitely something to consider. I think that could be a positive there.
Did they specifically say that this was for elderly or for aging populations? It was just all the patient populations?
Yeah, I think the elderly was increasing the burden of care and need.
That was kind of the context, wasn't it?
Okay.
Yeah.
Oh, okay.
I wonder as well, I'm just thinking about some areas of Scotland in particular. If I lived in some of the more rural areas, it might be really difficult out of hours, particularly. So I don't know if I would feel not heard, you know, not listened to and not accommodated. And I would maybe feel a bit frustrated about that or angry. Yeah, and the other thing I thought was maybe about some of the areas that are kind of a bit dangerous in the evening. So if you're elderly, you might be quite fearful to go out in the dark for appointments and things. You feel vulnerable.
And it can be dark from 3:30 in the evening.
Yeah.
I suppose the flip side of that is that, you know, if you've got a relative that is your carer or that takes you places and they're at work in the day, it's probably easier for them to get you there in the evening or at the weekend. The other thing is, it's, you know, I don't know about you lot, but I get really sick of, you know, hanging on the phone trying to get an appointment and then not getting one. If you're guaranteed that you're going to see someone, okay, you might have to sit there for a couple of hours, but if you're guaranteed that you're actually going to see someone, I find that quite reassuring.
I would say that could be part of the positive as well, is that it be a lot of GP appointments are to do with reassurance and to just rule out anything serious. And if you have a kind of a triage system that you're available on the day that you need it, it can be a way to get that reassurance more quickly than having to wait for an appointment.
Yeah, I think the thing there is that as long as you are ensured that you will get to see someone when you walk in, else I'd be a bit worried that I'm going to go there and there's not going to be enough like staff there to help. I think that would be a worry.
Laura, did you want to come in? You've had your hand up for a bit.
Yeah, I was just gonna try and provide a summary just in case they come back to us of where we're at so far. So the kind of feelings that we described is anxious about the skill mix available of the people who are delivering the service and whether they're going to be able to support your needs. That there is frustration, maybe feelings of exclusion or isolation for those who may not find that as accessible due to things like vulnerability in access in the evenings or access to transport, which isn't financially funded in those times, forgotten, vulnerable, relieved for those that you could just walk in and get an appointment and not have to be on the phone all the time. And that links with reduced anxiety and reassurance. So those are the kind of feelings that I picked out. But was there anything that I've kind of missed so far? I think for me, my instinct was definitely initially around this basic medical practitioner. I'd be like wanting some kind of clarity. What is a basic medical practitioner? What kind of information will they have? What can they do for me? Will they be able to meet my needs? So uncertainty.
Yeah.
Especially if they might not be able to actually prescribe or treat. They might only be able to then get you on to the next step. So then maybe you'd be seeing in that person that evening, but would you necessarily be able to get the treatment that you need at that same point?
I know we've been like focusing quite a bit on the evening aspects, but I feel there must be, I can't think of it, there must be some obvious benefit to having extra appointments on the weekend and having a walk-in opportunity there, right?
I think it was it Kay, you said things about people being able to attend appointments if they're working, and people being able to attend with carers who might have other responsibilities. So it might increase access. So people, I think that was where the reassured came in,
right,
as well, because people would just overall have more access, and but also reassurance by being able to go with somebody that could support them in conversation.
And the people who are looking for appointments in the daytime may feel that it being opened up in the evenings gives them more of an opportunity to get their appointment in the day as well. So there's more feeling of that the practice is there from around the clock, so it's more accessible and more available, generally speaking.
I don't know whether this is, oh sorry.
That's okay, go ahead.
I was going to say, I don't know whether it's relevant, but in the context of the whole thing, they were describing how, you know, there's a shortage of staff. And so my instinct is like, where are you going to get all these people from? Who are they? They're untrained. Oh my God, who are these people? Because there is no trained people available. So like my fear of who actually is going to be looking after me. But yeah, but that was just more a practical thing probably, rather than feelings. It's like, who are these people?
Well, it's not that they're completely untrained, is it? It's just that they haven't finished their specialist training. But, you know, you would get trainee GPs seeing you in the GP's office anyway.
Yeah.
So in some ways, it's not that different.
Well, would they be supervised?
Not necessarily at the time.
It's a bit like using physician associates, I suppose, in GP practices.
Yeah.
Yeah.
I don't know. I mean, my experience with them is that when they're trainees, they're often more thorough, because they've got to discuss the case with their boss later, or, you know, or if it's complex, then they will go and chat with the GPs. But yeah, I found that it's not a poorer service, but that's just been my experience.
Yeah.
You actually get better service.
Yeah, I agree.
They must have loads of people in training.
Yeah, not sure how it would work with them running a service just on their own with no GPs, if that is slightly different.
So they put in the chat, they put a bit of just the case description, so we could go back to that. So complaints arising, especially among young families who struggle to get same appointments for sick children. So yeah, so you do have that assurance that you can see your child seen on this day.
Yeah, I wonder about, I mean, one of my feelings when I saw it was, I would like to be able to get a same day appointment, yes, but I would rather not have it be completely walk-in basis. So it's great that you're increasing the hours, but if I have to go and sit for 3 hours with a sick child waiting for that appointment, that's not going to be ideal. I'd rather call in the morning and say, okay, you can come in the evening at 7. So again, it's a bit of like, yeah, it's a really good initiative, but maybe you've not quite thought through the cost. So you're shifting those costs in time to the patients who are already potentially time poor. And yeah, I don't know. Also, I was curious about whether it was going to be, you know, centralized, as in one practice out of a wider region, which also might have some which makes sense given the timings, but might then have some other implications on the cost of travel. Can you tell I'm a health economist? Like the costs are at the front of my head.
Yeah, I get similar to that, Megan. I was thinking about if you're waiting. So we've had something similar on a surgical ward here. If there's a lot of people waiting, then it becomes quite risky, doesn't it? Because they've not been triaged in any way.
Yeah.
So you don't really know if there's somebody, it was more from a practitioner, I was thinking, if you've got somebody waiting who's deteriorating, yeah, and that's a bit of a concern, and nobody's really looking after them while they're in a waiting room, I'm presuming. You know, nobody's observing them.
Are we just thinking about patients' feelings, or are we thinking about practitioner feelings as well?
Well, I think we were meant to think about patients, that's what I was saying, but I was trying to steer into practitioner.
Yeah.
Mm.
It's kind of a shame that we've been like restricted to just
I do
doing
think the lack of
the red hat. I'd quite like to do some of the other hats as well.
Let's just take another hat if we feel like we're done with this one. Like,
It does say that one of the options is considering new policy that evening and weekend walking hours where patients can see a GP without prior appointment. So sometimes they get to see a trained person, fully trained person. So it's not just the basic medical practitioners.
and here we have a facilitator that we can.
Hello. I came here to send the case description in the chat, and also to ask you how you are doing and if you need any help.
Yeah, I think we just feel like we've discussed everything, and we were thinking it would be nice to now think with a different hat on, but that's not really the rules.
No.
Or
we've
from
done
a
our
different
red-
position.
But you're finished with the red hat basically.
Yeah.
Well, I guess you can do two things. You can try and put another hat on, or maybe take a different perspective. For example, the GP's perspective, or yeah.
Okay.
Okay.
I guess we'd started to do that, hadn't we? We started to think from a sort of practitioner's perspective rather than just the patient.
Yeah.
How much longer have we got?
About 10 minutes. So we will come back to you and bring you back. Yeah.
Okay, thank you.
Okay, good luck.
So I think thinking from a sort of practitioner perspective, out of hours care does seem to attract more when urgent cases maybe, so that is there going to be a higher level of risk to be held by the practitioners, so they might be seeing something that requires more of a judgment about what level of risk the patient is carrying in terms of and what kind of safety netting they have to do to try and decide whether that person can do watchful waiting or they need treatment. That there's going to be a higher risk threshold to be carried by the clinicians if they're seeing more urgent cases that can't wait for an appointment.
So is that feelings of fear, or that they aren't prepared, or
responsibility, I guess, of the weight of responsibility, maybe, especially if they're not, especially the ones that have their basic medical practitioners. I don't know, but I'm doing them down a bit. They're very qualified, they just haven't got the extra bit.
Yeah, I think it's that fear of the unknown. You don't know what's going to come through the door. You know.
that's most days in a GP practice then.
This is true. This is true. But I'm guessing, I don't know, maybe would out of hours would people be sicker, or are we just presuming that? Maybe not.
I guess
people
people
might
feel
turn
that
up
they are
wanting their ears syringed.
if they're like, I want to be seen today.
Yes.
Because I'm really ill.
I don't know, I get the feeling that it might end up being used as well by people that are just at work and they're like, oh, instead of trying to make an appointment, I'll just go after work. And it might be, you know, something basic, like needing a prescription for something.
Yeah.
I think as a practitioner, I'd have fear about waits, because if you had a massive glut of people coming and then you couldn't see them, that you would get more complaints because people are waiting in situ, and how that would be organised.
It could also be quite frustrating, because if you start having people that could really have waited, you know, that didn't need to be seen in that day, it becomes a bit of a free for all when you get people turning up because they haven't, you know, ordered their inhaler and that sort of stuff, you know.
And are they having like a mini triage when they arrive, or are they just doing it in waiting order so that someone might need to be seen really urgently, but might have to end up waiting 3 hours to get the last because they arrived a little bit after someone else? Is it just literally who comes in the door first?
That's what it sounds like, isn't it? It sounds like they just rock up and it's first come, first serve, which could be a problem.
Mm.
For lots of people.
How does that play out into a feeling?
So the patient's frustrated if they feel that their concern is more legitimate than the person next to them.
So inappropriate referrals, or
I think stress for the staff as well. If you go out and see a big queue and think, oh my goodness, I'm going to have to speed up with my assessments.
So for increased feelings of pressure, time pressure.
Yes, because if you have a really busy night, how do you know you're going to be able to close the door when you're supposed to be closing the door?
That's true too.
I think having a longer waiting time can also, having a longer waiting time can be frustrating for the patients too if they're having to wait a long time. I don't know, like, especially if it's something to do with their mental health, it might not be beneficial for them to sit in a really crowded room if it's crowded for a long period of time. So it kind of depends on the patient and what they're going to the walk-in for, really.
Would you say
Yeah,
that?
yeah, I agree with that. Somebody who has got a mental health issue might actually find that impossible to do. Mightn't they?
Just to go back to the question, are they trying to decide between two new policies? So that one, the evening or weekend walk-in where parties can see a GP without prior appointment, or hiring additional staff to cover these hours? Or is it?
I think it's all part of
that's the same thing. Yeah.
I wonder also about, I mean, I'm relatively new to the UK, but I know that there's been a lot of junior doctor strikes in recent years, and I wonder about adding, out of hours and shifting it to these particular relatively low on the power pay totem pole staff, whether that's going to be well received, whether the care is going to be, then they're going to be demotivated by having to take on these shifts or feel, I don't know what the dynamic of that would be in terms of a feeling, but.
Yeah.
Yeah, it might be some people go into general practice, so they don't have to do that. They have to do the unsocial hours. Do the 12-hour shifts overnight at the hospital.
I think we've thought of lots of stuff. I think we've done.
We've had lots of feelings.
Lots of emotions and feelings, yeah.
Lots of fear and anticipation. There wasn't very many positive feelings though. There wasn't excitement or anything. It was more, there was reassurance. I think that was the only positive. It was more
Maybe
frustration. Hope.
As a patient, I could feel hope
and reassurance.
That they're trying to deal with this. They know it's a problem, yeah.
Yeah.
But it was like uncertainty, anxiety, vulnerability, forgotten, angry, concerned, weight of responsibility. Yeah. Exclusion, isolation. So it doesn't sound like anyone particularly thinks this is a good idea.
It's always easier to be critical, isn't it?
Yeah. I'm just wondering if there's, in the last couple of minutes, there's anything
positive.
Any positive emotions, or
I think maybe relieved that actually there is another option.
Yeah. Relieved and hopeful.
Yeah.
5. Welcome back, everyone. A few people still on hold. We will get everyone in, and then we'll get going. Perfect. Great timing. Hope it was enough time as well. I know that sometimes you're in the middle of a really interesting conversation in a breakout room and all of a sudden it just goes bam and it has to go. But I'm sure that we have some really good stuff to share within the group. We just have a few more people on hold. There we go. Perfect, thank you. We will start shortly just by sharing in each of the rooms. We'll have a speaker, and it'll just be sharing a little bit about the conversations that you had within the perspective of that hat. And I'm not sure, Nienke, if there's anything else you want to add from going through the different rooms and the different groups. Anything that you've observed before we get going?
Yes, so we will share the screen again, and then we have the sequence of different hats that we will use. And also we went into the different rooms, and I think we can agree that everyone was doing pretty well. We didn't have to help anyone. So that's, I think, a good sign. And I also believe the black hat was well, it was really easy, they said. So that's interesting to hear as well. So I think Rowan can share the screen and we can start with the plenary discussion.
Yeah, so we made a kind of a grid to moderate and integrate this discussion and get a bit of an overview of the different ideas that different groups have. So we hope that this is helpful. I will just make some notes for everyone's overview because we had so many colored hats and so many aspects of the configuration that we want to touch upon. We would like to start with the red hat. So that is the order that is advised if you want to solve a problem. To first, when you present a new ideas, and that is something that we explained before that we already did. So we suggested some ideas, and then we want to hear from the patients what they feel about this innovation, about these ideas. So please, the representative of the Red Hat group, please share your ideas, your discussion with us.
I think that's me, the red hat. So we take it. I didn't realize that you wanted it all as context mechanisms and outcomes as like a whole CMO.
It's no problem. I will see if I can structure it a bit. It's no problem if you didn't do it that way. I hope you did it a bit with a realist evaluation perspective in mind, so with some attention for what is going on behind or underneath, or what is going on in the context. But yeah, it's no problem if it's not that structured.
Yeah, no, because we just took the hats and the instructions for the hats of focusing on feelings. So we were focusing on the feelings aspects, which I suppose would be the mechanism constituent of the CMO. So I can see what we can do from what we discussed. So when we were thinking about the context of being a parent, then having greater availability of an appointment could help, and in times that are more accessible due to work commitments, people might feel more reassured and relieved that there's another option, leading to greater uptake of the service. I'm trying to create CMOs on the spot, so apologies, they're very, very basic. But the flip side of that is that the context of them, the professionals being basic medical practitioners and not have completed all the training, might create anxiety. So a parent might feel more worried about, well, anybody really, that we talked about different populations of people might feel more anxious about whether the practitioners will have the appropriate training to deal with their complex needs.
Yeah.
Another part of that is also whether they will be able to actually prescribe or treat those. So they might not take it up in those times because they might not think that they'll get the most appropriate prescription or treatment. Around that, we also talked about so there's in the context where people, so we took this, I think it was Megan mentioned that in certain situations older people have like vouchers for traveling within a certain time period. You know, like you can only use your passes within certain hours of the day, which might preclude evening or weekend travel. And so they, as a vulnerable population, they might not feel listened to, and might feel less able to access those services. There was also things around being vulnerable in the evening. So if certain people who are where it might be their only option to access the GP practice in the evenings, and it's dark, might feel vulnerable going into those practices at that time, and therefore not as able to access it. So subsidies for transport, concerns about training. They also talked about being relieved that support was actually available at those times. So when you haven't previously been able to access services, and that can be in different types of groups of people. So that might be due to work, or it might be due to carers not being available. So family members not being available to take people to appointments. They might therefore feel relieved, supported and hopeful that they can actually access the care with people to support them. We also talked a little bit about, so that was from the patient perspective, but we also talked about from the practitioner perspective, that practitioners, and that's just because we thought we'd exhausted some of the patient feelings, but they might feel an increased weight of responsibility. So if they have only completed basic training and there's no other support around, so in the absence of supervision or experienced GPs, in the context, they might feel a heavy burden of responsibility to treat and manage complex cases that they feel they don't have the expertise to manage, and therefore might become more stressed. We also said that because it's a walk-in situation, in the context of them being no kind of formal process. Sorry, I need to stop. Oh, in the slow down.
No, it's fine.
No, go on. Sorry.
So in the context of people, there not being like an appropriate process for managing the admissions, and people coming in on a first treat basis, so arrival and then treat basis, then they might have concerns that patients who have more urgent needs have to wait longer than those with less urgent needs, or conversely there may be more inappropriate referrals because of the increased ease of access to GPs. You get frustration from practitioners that there's more inappropriate referrals, just because of the ease, and therefore people feeling less stressed, more stressed and less satisfied with their work environment. Was there anything else that I missed from my group?
That is a very rich discussion. Lots to take on there, I think. I mean, I see you typing away all those areas in the red, particularly just with 15 minutes, Laura. So thank you so much for for sharing that. A lot of different, which is the point of this, getting very open, different perspectives, different feelings from both practitioners and patients. So I think that is a very very good start. Thank you very much.
Yeah. Yeah.
And the yellow group. Now we have the yellow. Anything from the yellow perspective
Yes.
of the program? Please, who's the speaker?
Yes, it's myself. Thank you. Yeah, we also didn't formulate these into CMOs, but a few ideas. Perhaps a lot of these overlap as well with what has been previously discussed, but a few extra ideas. I think most of these in the context of it being difficult to get a GP appointment in hours. So one of the things we thought is in that setting, if people are then have the flexibility of this new intervention and can get an appointment easily by walking in, they'll be less frustrated and the healthcare interaction may be better. So there may be less violence and aggression from patients and a more positive relationship built within the consultation because of that being eased. The other thing we thought is that in this setting where there's a delay in getting a routine appointment, this new service might act as a triage. And so if you could go to the out of hours service, if you did have a serious medical problem, you might be more quickly referred on to the help you needed rather than having to wait a long time for an in-hours GP appointment and then to be referred on after that. So it could actually expedite care maybe for the people who needed it the most. So that could be a positive thing. We thought about how it might free up appointments for people who did need to be seen in the daytime. So if some of the demand is being shifted to the evening by perhaps people who are able to attend at that time, then the groups that have been talked about, like older people who needed those daytime core hours appointments, might be able to access those more easily. Talked about the decreased burden on the patients, likely to be another positive from their perspective in terms of the ease, not having to wait in a queue, not having to coordinate with childcare arrangements or with other things. So easy, that sort of easy access around that. And yeah, talked about particular groups who currently find it difficult to access in hours practice because of those things. So people who work shifts, perhaps, who can't attend a normal appointment, they might be advantaged by this system. There's lots of other things I've written down, but I think they're some of the more interesting ones.
That's great. Thanks, Freya. That's brilliant. And again, one of the nice things of the yellow hat is this glass half full situation, you know, the positive things that we can see, which is great, that the patients, the providers. But then we also have the glass half empty. And this is where the black hat comes in. And they may share some of the, it's maybe, you know, as they say in Spain, you know, the good is not as good and the bad is not as bad. So let's go for the black hat. After seeing those positive things that could happen from this change, what are some of your devil's advocate perceptions in this case?
Wonderful. I feel terrible.
No, at all. And I mean that. I mean that in the best way possible. And I say that because it's as important as we know, from a realist perspective, because it's a realist session, to know when it works and when it doesn't work, in the positions where the program may be efficacious with intervention, or maybe we maybe see a change, but also the other. So actually, this hat, I know our position did, you know, in a bit of a comical way, but in a way, it is equally as important. So please share.
Wonderful. So I'm just going to say to the other group members, feel free, please, to also jump in and add to the rich discussion. So I did try to structure it a little bit into like kind of quasi-SIMO configurations here. We sort of discussed it by role in terms of like the context and the setting, but also we sort of elucidate what the mechanisms outcomes. So starting with the role, there's a lack of clarity depending on I think where we're coming from. So I'm coming from Canada and I think most people are coming from the UK or Europe. So we thought that the lack of clarity in the context between what exactly this role entails, it could either lend itself to somebody who's like in a position of a physician assistant or associate, depending on where you live, or it could be like a medical resident or trainee. But both of those pathways results in this sort of similar mechanism of do they feel that they have the prerequisite training to take on this workload? And if they feel they don't, then it could result in this target population actually not being served after all, given that this population often has more referrals or complexity than other members of the public. So that was a very, very big striking thing that we noted was, does this particular service directly impact the population the way that was intended? If they don't feel confident in their abilities. The other bit around this role that we discussed was this population, like any, or this role, so the physician assistant or the medical trainees themselves might have be caregivers or take care of family and older adults on evenings, weekends. So this could become a situation where they feel very overwhelmed and stressed with what is basically being a sandwich situation, which could result in, again, the target population not being served because you don't have people who are able to do this work. But it actually could, if they're forced to do this work, perpetuate some very serious inequities on people who are already very burdened. And if not them directly, it could impact their partners, like their life partners or people at home who have to kind of, as a secondary result, end up having to pick up this role if they have to do this evening and weekend work. If these are trainees, we were talking about how there could be feelings of unclarity, or lack of confidence that this work is building towards career progression. So is there a clear pathway or pipeline when they take up this work, or is this really just work that they're doing that doesn't count or is invisible within the schemes of how they're currently evaluating and being assessed for their competencies? Of course, that could also result in their lack of willingness or overwhelm to take on this work on the evenings, weekends. We talked a bit about how from the organizational side, there might not be prerequisite infrastructure in place to create documentation or referral pathways or laboratories, diagnostic services open on weekends and evenings, or does this create even more funneling on Monday morning? Or could people incidentally slip through the cracks, which actually creates legal issues? So a key mechanism in there would be do they feel confident in that they know what the documentation structures are? Are they aware of what they are? Do they feel educated? And is there safeguards in place to make sure that if incidents happen, that there's some sort of guardrail to make sure that they can get back on track? We spoke about the perspective of the members of the public. So first, the general members of the public, would they treat this after hours almost like an extension of A&E, which it sounds like no matter where you live in the world already is very burdened and overwhelmed with inappropriate access. And the delays are getting pretty significant. So from the perspective of the members of the public, do they feel entitled to these evening and weekend appointments? Maybe they feel they're very convenient, but it doesn't actually alleviate for the people, the target population, because they're taking up these extra spots anyway. And then it just shifts one funnel or one sort of area that's really burdened to another, or maybe it just creates another secondary stream of blocked access. We also spoke from the perspective of the target population, so families and older adults. They might, as mentioned, have more complexity anyway. So do they feel as though this structure is going to serve them, first of all? What would help them feel confident that they can get their needs taken care of at these appointments? Or would they just wait until 8 a.m. on Monday anyway to join the queue and to try and get an appointment? And then we also spoke of, for a lot of these individuals, maybe they don't actually want the evening and weekend appointments because they have to take care of other children or they have other commitments. So that might be something that maybe they could benefit from the spots that would open up during the weekday if other people were to shift to the evenings and weekends. But that's not a guarantee. So that might not actually help. Also, it might end up in a situation where for this population, which is already stressed and lacks accessible care, they might be stuck just waiting in first come, first serve queues all the time, which could take hours. So instead of one daytime appointment and knowing what time to show up, they could be on a Saturday for 7 hours with a sick child. I think the last thing we spoke of no, I think that's it. Does anyone else, did I miss anything, or does anyone from the group have anything else to jump in? I think Black Hat team was pretty busy. Be the devil's advocate.
I can tell.
Denise, very
Oh
busy.
no,
Yeah,
scope creep, nurses. That was the other role. Sorry, I almost forgot that. There's some professionals like nurses who are very, very capable of doing this work, who might feel that they have to pick up kind of, again, invisible work. And is that appropriate, and does it actually serve the target population?
Yeah. Sorry, was there anyone else that wanted to? Because that's great, Denise. Yeah, please. No, that was someone, please.
No, I wanted to say, Denise, that you did a good job also, and the other groups, by the way, by not only thinking about the patient, but also other types of stakeholders that obviously have a role here. And I was wondering, Denise, do you also see, or have you discussed how the patient is influenced maybe by also the ideas, feelings, and in this had the negative perceptions that other stakeholders have. So if a negative stakeholder also influences maybe the patient, or do you see those relationships with patients?
We talked a little bit about what could occur. And I think it's interesting because this came on a flip side of what I heard. I think it was the other team say, which is when people are in a queue, like first come, first serve, it could actually result in more feelings of frustration and violence. So they might actually become more exposed to these types of situations when they otherwise wouldn't have. So we did touch on that a little bit. So it's sort of like they become, even if they themselves, these families and these older adults aren't the ones who are frustrated and being violent, they might just end up in a scenario where they become extra vulnerable, or they perceive themselves as maybe, even if it hasn't happened, becoming vulnerable in those situations. I don't know if that answers that question.
Yeah, it does. Yeah. So it can, and yeah, I also believe you made very clear that also the feeling of professionals also feeling secure and safe, and the protocols and guidelines in place, I think makes it also better for patients, or that could also have, if that's not arranged well, that could also have a negative impact, obviously, on patients. Yeah. Thank you very much for your extensive summary of your discussion. We only have, I think,
fascinating. I mean, just wanted to touch on, like, essentially what you've built there is just a massive risk assessment for this program, and looking at where does the program hinge on. What if something was going to happen, or we're going to take out something, where would the program crumble? And this is where I think the Black Hat becomes a very interesting one. And as I said, a very important one, to look at it not only within the program, but as you mentioned, also beyond the program to other stakeholders. So perfect. And yeah, thanks, Rowan. I think last but not least, we have the green hats, which of course, are there any other options? Is there anything else out there that any blind spots that we're looking at here, essentially? So any ideas just before we move into the Q&A?
Yeah, I'm gonna feedback the green group. So we had lovely discussion and tons of ideas, and I've tried to just group them into some themes. So anyone in my group, please let me know if I've forgotten anything here. But so one of the sort of alternatives we were talking about was actually the long-term sustainable GP workforce and increasing that capacity. So we were talking about things like funding, increasing wellbeing provision for GPs, training, and cross international partnerships, immigration training across different countries. So that was one of the kind of alternative approaches that we looked at. Another theme was really focusing on prevention, so reducing the demand for GPs through improvement of prevention of ill health and improving well-being in the population. We also talked about increasing the availability and the uptake of alternative sources of help and other professions, so that are not medical, not GPs. So pharmacists, using pharmacies, allied health professionals. So yeah, that kind of angle, and potentially with those being available at different hours, using this sort of idea, but with other health professionals. We talked about the idea itself, the drop-in being also available online or by phone, so people could access a drop-in service. That doesn't mean they have to physically go to the GPs if that's something that's appropriate, or having it as well potentially in different physical locations as well as a surgery. We also talked about measures which could enable people to access the GP during the day easier. So rather than increasing the provision out of hours, actually making changes that would enable more people to access in the day. For example, things around childcare, transport, and policies for employers around releasing people to attend GP appointments during the day. And then another thing we talked about was this policy itself, so how it could be supported with things like a triage system, some kind of use of AI for signposting or managing different kinds of appointments. And we talked about continuity of care, shared notes, ensuring the system was all joined up, and those kinds of measures. So yeah, I think they were all the big sort of themes that we spoke about.
Brilliant, thanks, Caroline. Again, some very interesting stuff as well to look at it. I think as well, all the hats are so valuable and so important. I'm learning so much just to see everything that every group has been sharing here, particularly looking at it from a realist lens and how we can refine, refute, or confirm our program theories. And this is just from a little prompt, a little CMO prompt that has happened. So you can imagine when you have bigger stakeholder groups and a little bit more time. So thanks, Caroline. And just before we move on to the, because I don't think there was a blue hat group, I don't believe. I think we didn't go into the blue hat just yet. Was there a blue hat? There was 4 groups, wasn't there?
No, we are the blue hats.
Yeah.
Yeah.
We are the blue hat. Fantastic. So from that end, just before we move into the Q&A part of the session, Nienke, Rowan, Dorijn, is there anything you want to add from what you've heard and from everything that you've experienced using this approach with Realist? Any final comments from what you've seen or heard in this exercise of plenary group?
Yeah, I think one of the takeaways for me, and it's something that you did very well, is I think in each of the groups the assignment was mainly to focus on the patient perspective, but I think it's natural that you also have a look at other perspectives also for the professionals. You thought about the organizational perspective, and I think we saw some. I think we saw some similarities between the groups. Also looking at my colleagues who might be better in following this discussion, because I also had to take notes. But I think there was a lot said about feeling safe or having anxiety as the opposite, fear that people will not get the right treatment. Fear of being vulnerable. But on the other hand, I think there was also a lot said about mechanisms that you get more quickly referred, you get treated. That's also, I think, related to feeling safe. So I think it could be, it could have different sides. Yeah, and I think you also thought very well about alternatives that you had. Yeah, I don't know if.
Yeah, I agree with what you said, and also I think, and I hope for everyone behind the screen that I really saw the order of these hats fit well on each other. So even though you didn't talk to each other in between the breakout rooms, right? They really they kind of talked how do you say that? They
create a story.
Yeah, they create a story kind of responding to the previous head. So we first had the red hat commenting on our green hat, right? And then you have the positive sides, and then the black hat comes along, but you never end with a black hat, by the way. That's really important. So then you end on a positive note with all these types of innovations, and obviously you can even continue the cycle again with talking about these innovations that the green had extended with, and then going it back again with what do you feel of this, what are the positive sides and negative sides, until you finally come to a solution. But I think, like Rowan said, there are lots of mechanisms and contexts coming about. So even though some of you didn't necessarily focus on, okay, we need to find a C, M, and O, we can still find them in these discussions coming back when you have a certain way of looking at the problem. So with the why it works, how it works, for whom it works, and also like Alejandro said, right? We not only look at if it works, but also what if it not works, right? So the black hat is really a crucial part in this as well. So yeah, I think this is also really quickly done, right? So if you would have more time to write it all down, I think it will be even more extensive. But it already shows like how, in brackets, easy it can be to like build this up, so you can use it for an initial program theory or also to refine your program theories. But not only realism, also outside of that, I think it's helpful.
Yeah, I think also that the hats are often used as you did now. So to brainstorm about all kinds of ideas that are out there, all kinds of perspectives and needs and feelings, but also drawbacks and from all kinds of actors. So I think yeah, maybe not all of it if you would dive into it and do interviews and seek for literature. Maybe not all of it would actually hold and be something to do research on, but I think it's a good starting point to switch between the hats and switch between actors. Yeah. Maybe I think we have a bit more than 10 minutes left, Alejandro, right? Then
we do indeed. First of all, I guess that first things first, thank you so much for organizing and sharing, digital clap for the team in the Netherlands. Thank you so much for that. And also for the technology, it's worked. People have gone into rooms, they've had discussions, fantastic. Because I know sometimes our attention goes to that a lot of the time. So congratulations. And we do have some time to go into some questions now. And just a little summary into what we've been through today, because I know we've been here nearly for 2 hours. We had a little intro to Realist Evaluation in the first part of what it was, why Realist Evaluation, the importance of co-creation, specifically from a realist lens. Then I introduced the Bono hats from a realist lens. They can be used in other areas, but specifically from a realist perspective. And then we went into the breakout rooms and had a discussion. So based on that, if anyone's got any questions, you can either raise your digital hand up, or indeed you can put them in the chat. Any questions that we don't have time for, I will collate them. And I will provide them as well to Jo at the end, so she can particularly share some thoughts maybe in the Ramses list. But there was one specifically that I saw that was specifically around yeah, thanks Caroline, that's a great question. That was actually question one on my list was a question, but I know you have to leave, but let's have a conversation around that in a different time, because I know you have to go and I know you want to hear the answer. So we'll definitely put that into a different, because it's a very important question from an ethical perspective and also just generally. So we'll definitely keep that in mind. Thank you, Caroline. But there was one question from Laura here, which is specific around the hats that I just want to touch on, that says, from a practical point of view in your stakeholder advisory groups, would you share your initial program theories and then ask people to consider the hats as a practical way to really help people understand how to engage with a realist perspective? So do you have any views on that question?
I mean, like we mentioned first of all, very good question. And second of all, I think it's a good tool to use because, like I've mentioned before, people mostly walk in with a certain hat already on. So it's a good way to just really say, okay, right now we're looking at this, in this case, in this initial program team with this specific perspective. So people are really forced to look at it from that way, and you won't only get one side of the story. So maybe only the black hat, so only the negatives around that program theory. But like Rowan also mentioned just now, is that you can also use this before. So just when you don't have anything yet, you can brainstorm until you get, like, as you've seen, the document is quite full with rich information already. So that could also help you with the start to those initial program theories.
Yeah, and I also believe that it's more the philosophy behind the hats is very important to bring to a realist interview, for instance. So like Nienke says, people sometimes have a certain hat on, but that's mostly not the complete story. So they always feel, although it's maybe for a small part, but they always also feel kind of a positive thing, or they can tell you something about if you change this, then this could be positive for me. And you're always, of course, in realist evaluation interested in that complete story. So yeah, I think it could be, you could really practically use it, but it could also be used, and I think many different co-creation instruments could be used for that. It could also be used as a bit of an attitude and a philosophy that you can take into account in the realist research.
Yeah, and also with what you're saying, right, the topic guide of a realist evaluation, for example, there's also questions like, so why do you feel this way, or what is it that is good about this, or maybe what is it that it doesn't work? So then you could also keep those hats in mind when making your topic guide, for example.
Brilliant. I think that's really useful, Nienke, Rowan. Laura, I hope that's answered the question as well. If you're in, thank you so much. There is a question. This is related to this one as well, from Alan Krita, commenting specifically at loving the hats approach, fantastic, and convinced that this is a good methodology for developing an IPT. So initial program theory for those new to Realist. You think this will work well for stakeholder engagement, for refining the theory and arriving at the final theories? So I guess what I understand from that question is, at what stage do you feel the hats could work best?
Yeah, I think it could be various stages. So if I understand it correctly, the question is whether it could also be used not only in a quite early stage, but also in a more advanced stage, reaching
for refining.
Yeah,
that's what I mean. Yeah.
Yeah. Yeah, especially I think we answered it partly also in the last question, I guess. I think it can be used for like I said, for brainstorming, if you want to design or unravel an initial program theory. I think there it can give you loads of ideas about what actors do I have, how do they feel, what drawbacks, what benefits do they see. And I think indeed, if you reach that stage of testing that program theory, it can also help you to get that full picture and full story by stimulating people to not only think about the negative things, which they might be more inclined to do that than the positive things, but also indeed think about positive things, or maybe think with you about alternative ways to look at it. So
and think more about feelings as well. That's something people don't tend to do usually.
Yeah.
So it encourages you to think differently. Yeah.
Yeah, and I think especially when I'm looking at my research, I'm doing a reader's review. Sometimes the mechanism can be difficult to. I see a cat walking the street. Can be difficult to extract from literature. So then going about the Red Hat, for example, using those in the stakeholder engagement sessions could be really helpful to get more grip on those mechanisms. Yeah, but I agree with what you said as well.
Brilliant, fantastic. Thank you, thank you so much. And I just from my perspective, well, I can see it in different stages of the process as well. You can certainly elicit some of those initial ideas using the hats from more of a blank slate, so to speak, if you want to, or they're presenting some initial program theories, and then at the end as well. So certainly can be useful. And thank you so much for sharing those ideas. There's one there's a final question. Just because of time, that is from Alan Krita. Alan Krita, would you recommend any other tool for refining an IPT? But it's also from Denise saying, if there are any additional art and design-based techniques that lend well to the realist approach, and we involve actors and stakeholder groups, knowledge systems. So with the hats, have you either used anything else to complement them, or any others that could be useful to refine or refute or confirm our IPTs?
Yeah, that's a good question. Yeah, I think various approaches, frameworks from like stakeholder engagement, co-creation could be helpful, could be used. Yeah, I don't know if in any of the projects that we did, we used a different format.
Yeah, of course, interviews. But
Yeah. Yeah, I think not at this moment. I also see a hand up, but I do know, for example, for because now we have all these different hats, right? Like I know design thinking also has great ways to engage stakeholders. For example, with the patient group I mentioned with type 2 diabetes, we did an crazy 8 sketching, like 8 as in the number 8. So in 8 minutes, they sketched 8 IDs on the problem at hand. So you can also use something like that, like 8 IDs or 8 solutions, or really brainstorming can be done in very different ways. So there's lots of ways. I know there's also the co-creation compass, which was designed in the Netherlands, not by us, but by some other very good colleagues of us. So I can put it in the chat. It's really helpful. It's a document that is interactive, and you can have there's different kind of bubbles that says, okay, I'm interested in doing research around this area, and then you can click on the different things. It's very an interactive document, so you can see many different ways of co-creating, and I think you can also kind of adapt to what you need and what is necessary.
Absolutely is. I mean, there's 3 things that come to mind as well: realist ripple effects mapping, photo voice, and vignettes. Those are 3 other ways that you can think about it. But I know there is a hand, and Faye, last but not least, please.
Hi, just because I'm using Lego in my research, my realist evaluation with children, and I think that would lend itself so well to the kind of color coding, and you're using the bricks, the different colored bricks within the model of the intervention that you're asking people to build. There could be something really interesting there about how you use the thinking hats and the colors within Lego to really bring something to life creatively. I just thought I'd add it in.
Oh, that's a good idea. Thank you so much.
Yeah, that's brilliant, Faye. Maybe we can, we can ask Joe for the next session if we forget about it. So we'll get you in to speak about Lego and
we'll build something. Yeah.
Oh, that's brilliant. Thanks, Faye, and thanks everyone. I know we're just reaching time now. There's a couple of questions in the chat that the ones that haven't been answered, I will collate and I will share with Joe at the end. But for everyone here, I guess from my end, thank you so much again. I've learned a lot. I think it was fascinating to hear about the hats, and just again with a prompt and just some time and getting some people thinking together, how much output one can get from this approach and through getting stakeholders together. We could be here all day certainly talking about the topic. So thank you so much. Nienke, Dorijn, Rowan, is there anything else you'd like to say just before we wrap up?
I think we also want to thank you so much for coming to this online workshop. It was a gamble how it worked out, but I'm really grateful and happy that everyone was so excited and involved, even though it was digital. So I think, it was a great session, and
thank you very much.
Yeah, thank you very much for the
Thanks,
invitation, everyone. And that we could share our stuff here online.
Last but not least, I've just been asked, so on the chat, you have also, if you have any questions about the Realist training, you can email inquiries at the Realist Hub. And also, this talk will be edited and posted onto the Realist Hub YouTube channel, but it will be advertised on LinkedIn, so you can see everything through there. Again, thanks so much, everyone. Really looking forward to seeing you in the next session. Thanks as well for the team for sharing an interactive, useful approach, again, to add into the toolkit of realist evaluation, realist synthesis, and stakeholder co-production, which is, of course, something that is still evolving that we can all learn from. Thank you very much, everyone. Have a lovely rest of your day, of your week, of your morning, of your evening, wherever you are in the world. And I'm sure I'll see you very soon. Thank you so much.
Thank you.